Table, I would like to say a few words on the background of this conference. We had organized on May 30th, we had organized an event on India's tobacco policy on the eve of the World No Tobacco Day. The speakers of that event included parliamentarians, lawmakers, eminent doctors, and policymakers. So, what had come up in that conference was, as Dr. Madan Gopal, Dr. Nimesh Desai, and Dr. MC Mishra would recall, what had come up in that discussion was that many speakers had touched upon the subject of harm reduction. So that's when we realized that the opinion on tobacco harm reduction is sharply divided. There's a section that believes that giving tobacco users less harmful nicotine-containing products can avoid around 5 million deaths globally. And in India, this number is at around 1.4 million. Another sizable section also believes that harm reduction products will only create another generation of nicotine addicts. In India, we have as of 2019, in India, we have a total ban on all nicotine delivery products as per the ENDS 2019 Act. After that year, there has been a flurry of regulatory action with different countries imposing as well as lifting bans. And here in India, the market reality is that despite the ban, all kinds of innovative devices delivering nicotine are readily available. But because of the ban, there's hardly any discussion on the scientific evidence emerging from the rest of the world. So that's the background to this conference. And through this roundtable, we expect to initiate a discussion on this topic on harm reduction with doctors on either side of the spectrum presenting scientific evidence in support of their stance. On behalf of Policy Circle, I welcome you all to the Policy Circle Roundtable on tobacco harm reduction, the risks and benefits. Thank you all, especially our speakers today, for taking out time on a Sunday morning. And I would also like to welcome all our online viewers. Thank you for being here. And welcome once again. Thank you. I'll hand over now to Lottie, who will be introducing our eminent speakers one by one as she invites them to speak. Over to you, Lottie.
Yeah. Thanks, Sajana. Before we go ahead, I'd just like to give you a few pointers. First of all, kindly keep your mobile phones on silent mode, or you can switch them off if you please. And each speaker would be given a maximum of 8 minutes, right? So I'll prompt you a little bit by the time it's 6 minutes or 7. So please adhere to the time limit so that everybody can have a word. And because we are really expecting a lot to come out at the end of this conference, and we'll be breaking for tea, say around 11:30 or so. And after the end of the conference, I would like all of you to join us for lunch. So moving ahead, we have with us Dr. Nimesh Desai, Senior Consultant of Psychiatry and former Director, Institute of Human Behavior and Allied Sciences, Delhi. Dr. Nimesh G. Desai has served in premier academic institutions, namely NIMHANS, Bengaluru and AIIMS, Delhi, before joining IBAS. He worked at IBAS for 23 long years in senior positions for its development and growth. Dr. Desai is also a qualified public health professional and has been an early pioneer in the field of alcohol and drug abuse treatment and prevention, including tobacco control. Dr. Desai has made an immense contribution in making IBAS an institute of national importance. He is the recipient of the Bharat Swasthya Samman Award for his outstanding contribution in the field of psychiatry. So may I request Dr. Desai now to kindly introduce the subject and speak on the need for discussion on harm reduction. Dr. Desai.
Thanks, Lottie, so much. Anil and Sajna Nair, they seem to have stepped out. Thanks for organizing this. I was looking around and it looks like, with all respect to every other colleague, it looks like the AIIMS faculty alumni of the 90s. And with some young colleagues like Atul Ambekar with us. But Sunita ji, Dr. Mishra, Dr. Killani, many others. It's a great pleasure. I'm going to make an initial remark or two before we come on to the slides. On a Sunday morning, as Lottie and we were discussing, I really think that Saturday evening, night, or Sunday morning is highly inappropriate for a serious scientific academic policy discussion. I individually am at least firmly rooted in that. And so let me begin on a bit of a lighter note. As a psychiatrist in medical conferences, on public health meetings, Atul and I are used to, if I might say, be the dessert. Usually, the psychiatrists or the mental health people are the last in the list. So I've got used to saying that I'm happy to be the dessert. Today, I'm happy to be the soup or the starter. I'm also going to try and see that I try and put before you the range of items available for you to choose from and get into nibbling at each of them. My other area of interest besides culinary sciences has been cricket, and if some of you will remember, there was this short period, not so short though, when Sunil Gavaskar and Krishnamachari Shrikant used to open the Indian innings. And there was such a contrast from the sedate, calculated, totally moderate pace, professionally played Sunil Gavaskar to the Krishnamachari Shrikant, devil may care, hit out attitude. So I was wondering what my approach should be, and I thought I'll try and do a mix of that, but certainly more of Sunil Gavaskar than Krishnamachari Shrikant. Although some of you might believe that I might bet like Krishnamachari Shrikant, but today I choose not to. So I'm not going to try and get into one basic issue that Sadhana and I referred to. And that one particular set of products that seems to be banned. I'm sure there'll be many opinions from very learned colleagues here. But I'm going to try and if we can now have these slides, please. I'm going to just try and lay the background for why do we need to discuss this so much, and what are the background facts in the science and in policy implementation as I see them. As it was said, last 40 years or so, I've been involved in alcohol drug abuse treatment and prevention. And as I said at the last meeting, in the 80s and 90s, there was virtually no talk on tobacco treatment for sure. Tobacco prevention was a focus. Tobacco prevention included two major strategies, as I'll show you. Either legislation or increase awareness and see that people don't ask for it. There was no recognition till the turn of the century for treating people who were addicted. Sir, slide show kar denge, please. Yes, please. Next one. I don't know if anyone of you has seen this in one of my earlier talks, but I can't keep myself from using this. This is the state of the Indian society, I really do think, for good and for not so good reasons. Next one, please. This is the other reality. This young kid of possibly 1 year or 2 years, sitting on a charpai in a village situation, smoking away, what tension I had. Well, when you think there's been no tension for that kid out there. Next, please. With all respects, for those of us who might have drawn salaries from WHO, apologies, I haven't. But the fact is, the next one, please. We do, all of us around this table, and many others who are online with us, and many other people do care. Do care, especially about tobacco use and tobacco control. And we should take action, and I underscore, based on science and pragmatism. Those are the two operative concepts, it seems to me. Next one, please. Now, I will not elaborate, like I said, too much on tobacco control activities besides the highlights, also not on the strategies for tobacco cessation treatment, but really the rationale or the need for harm reduction approach in tobacco treatment. That's going to be the limited scope that I plan to take. Please, next one. Okay, I'm sorry, I don't think you can see this too well, but like I was saying earlier, in the 80s and 90s, including the FCTC of 2004, the Framework Convention had very little on tobacco treatment. Forget harm reduction in tobacco treatment. And so it was kind of, as I felt in the 80s and 90s, the tobacco treatment was falling between two stools. Post turn of the century and last 10 or 12 years, it's increased. It's become better. Next one, please. For those of us, for those who might not be very familiar with the idea of scientific definition of dependence, these are the criteria that ICD or DSM generally use. Next, please. And what was not realized for a long time, including in medical circles, is that there is physical dependence established, at least now for 20 or 25 years. This whole idea of it being only a psychological habituation was such a myth. Next one, please. A quick recap, more for our younger colleagues and of course my learned colleagues for what are the independent, what are indicators. But next we'll show you something important. Next slide, please. I've tried putting down here as to what specialties see the after effects of what route. And I want to highlight that in India, unlike the West, smoking is not the route for tobacco use alone. And half or two-thirds of our health issues and public health issues are actually because of the oral route. And we can never overlook that. So while our pulmonology and surgical discipline colleagues, and including cardiothoracic surgery, we have one colleague here, while they might see more the effects of smoking, there are dentistry colleagues and gastroenterology and oncology colleagues. We have Pavan, who is a past master from oncology to tobacco cessation, and he'll bear this out. So we need to really realize the public health issue of both the routes, even when it comes to treatment, that limited focus. Next one, please. Now, as I already alluded to, why tobacco cessation? Besides every other reason, one thing, if I might remind all of us, that I'm sure all of us have known at some point of time, across behavioral addictions, if there is one thing that is known, it is that people start drug use by modeling, seeing others use, especially for smoking and oral tobacco use. And so if you treat one person effectively, you are actually preventing a whole lot of others to even start. Next one, please. Now, in 2001, we started this at IBAS, and then it's become a huge network of services. I'm going to very briefly present the data for that. Next, please. These were the steps that we followed. Next. I am sure my friend Pavan and other colleagues will talk about these 5 A's, but what's important next, if you show me, is the data from, next slide, please, sir. This is the data that the WHO country network presented in 2012 in the WHO bulletin. And please see, for that concerted effort, the success rate was for abstinence. And this is the slide that's crucial. 3 months, 26%, 6 months, 21%, 9 months, 18%. That's the reality of all chemical addictions. Next one, please. Sir. I want to put across to this group the concept of what I see as biobehavioral disorders. All chemical dependence, all behavioral addictions, I dare say the HIV pandemic was essentially a biobehavioral disorder. Even the recent pandemic was essentially a biobehavioral disorder, if you reflect. Next one, please. And so, what matters is that we must recognize that the success rates of treatment or prevention, especially abstinence-oriented treatment, is low to moderate at best with best efforts. Leave alone what some of us might claim as my clinic has success rate of 90% or 20% or whatever. But please, let's be sure. In my experience in the last 40 years, the science of addictions, and Atul will bear me out, has learned to become pragmatic, not to hit your head against the wall, and keep breaking it. The very old good saying, don't let the excellent be the enemy of the good. So science has learned that you not only accept the lower goals, but you even work towards those. Don't aim too high. When you start high jump in athletics, you don't ask the instructor to put the bar at 6 feet. You put it at 3 feet, go to 4, go to 6 feet. Next one, please. Now, leading examples of where HR approach has succeeded, and I'm sure Atul will elaborate on this, methadone substitution, opium registry. One other example, campaigns against drunken driving. That's an example of HR. Needle exchange programs for HIV and IV drug users. I even go as far as to say the idea of protected sex for HIV prevention is essentially a harm reduction approach, if you pause and think. I won't even get into the details of how our respected father of the nation For a minute, I think somewhere had lost the bearing to say celibacy for family planning. So extreme solutions don't work. I don't think we need more example. And the unlock activities in 2021. The best would have been to lock down for 2 years. Did we do that? No, we didn't. Next, please. There are also examples of where HR has not succeeded. Let's recognize that. And so, to repeat, treatment is also prevention. As I said earlier, I underscore this as strongly as I can. All NRT methods are essentially harm reduction. The controversy that Sadhana referred to seems to be only about one set of products, and I, for the life of me, can't understand why. About vaping, I leave it to people to follow. The important part is this is not going to be relevant for oral tobacco use problem that we have. So how are we in this country going to do harm reduction approach for oral use is the question. And I think that's it. Thank you so much. Sorry, Lottie. Next, Bharat sir.
Well, thank you. You set the ball rolling, though you did, you went overboard. Yes, you exceeded. So I would request the others to kindly fall into that bracket. So the next speaker is Dr. G.C. Killani. He's the chairperson of PSRI, Institute of Pulmonary Critical Care and Sleep Medicine. Dr. Killani was the head of the Department of Pulmonary Medicine and Sleep Disorders at AIIMS, New Delhi. He did his fellowship in critical care from Mount Sinai Medical School, New York. He is also the chairman of Credential Committee of Indian Society of Critical Care and Medicine and member governing body of Indian Chest Society. Dr. Killani will essentially speak on the thinking behind ENDS Ban Act. So over to you, Dr. Killani.
Thank you, Lottie. Good morning, everybody. At the outset, I'll thank Mr. Anil, Sadhana and Jaiswal. Mr. Jaiswal for bringing me again here. The last meeting that we had on this tobacco thing, I was cornered by policy makers, administrators, and lawyers. I was singled out. And there was a discussion on electronic cigarettes, electronic nicotinic devices, where they did not know that I was sitting there. And I gave them sufficient evidence why it was banned. Where's the next, please? So why I am with you? Because this white paper, which came by, which was ICMR paper on this ban. This was under the chairmanship of Dr. Srinath Reddy, which I was one of the expert member, who threadbare discussed the role of electronic cigarettes. And in next 7 minutes, I'll emphasize on you why this August committee recommended to the government that electronic cigarettes or e-cigarettes should be banned in this country. And it was amazing that the government of India came out with an ordinance after going through this white paper. And that day I didn't get sufficient time, as Mr. Anil said, to prove my point today. Thank you so much for bringing me here. So this is what it is. What is electronic cigarette? Of course, this in August gathering I need not say. It's actually resembles a cigarette or a cigar. It has got various fancy shapes, and it has a battery. It has a solution. This solution contains nicotine. Along with this, there is a propellant solution, which are hydrocarbons. I need not name them. So when a person inhales, he has a feeling of smoking a cigarette. He gets a nicotine, which is an addicting substance. But along with this, he gets a uncontrolled amount of hydrocarbons, the chemicals. So the harmful effects are that not because of nicotine. I'm not talking about that. Of course, nicotine is a harmful substance. It does cause addiction and all those things. But the thinking behind is that person is addicted to nicotine. The tobacco cigarette or BD or whatever contains about 4,000 to 7,000 chemicals, which are causing lung cancer, cardiovascular disease, and so on and so forth. So why not give him nicotine minus the other substances, so that he continues to enjoy nicotine but does not get the harmful effects. But the e-cigarettes affects almost all the parts of the body, and typical cartridge contains about 20 cigarettes, equal to 20 cigarettes of nicotine. And when the person inhales, he does not know how much cigarettes he is smoking in one go. It's an uncontrolled amount. And there are various amount of carcinogens, which include acetaldehyde, formaldehyde, acetone, etc., etc., etc. And there are chemicals which have potential to cause fire. And it has been shown in the animal experiment that these e-cigarettes, when they did a biopsy of the mucosa, they have a carcinogenic effect. They make the DNA change into the malignancy. So I need not recite all those things, and it can rarely cause explosion also. And there are reports of deaths caused by e-cigarettes. With that, the US FDA have said that it demonstrated the presence of diethylene glycol on some ants, which can lead to mass poisoning and deaths if inadvertently substituted, and there were additional presence of genotoxins and animal carcinogens, which are proven by the studies. And it's a matter of great concern. That is what US FDA has said. Now, studies on use of e-cigarettes, I'll be talking about it, because unless I tell you some evidence, you will not believe. In 2018 in United States, 21% of high school students and 5% of middle school students reported to have used e-cigarettes in last 30 days. India, the data are not there, but the people who actually have the knowledge, it's being used and abused despite being banned, as Ms. Sajana pointed in the beginning. And WHO report showed that the use of ants amongst non-smoking, I want you to understand, non-smoking use have increased by a factor of 5 to 8. Now, impact on young minds. How does it? When you talk of harm reduction, it starts at the teenage, because majority of smoking starts in the teenage. The use of ants by minor doubles their chances of starting smoking, because they hook to the smoking nicotine, and then cigarettes are so easy to get. If they don't get this, they will go for the cigarette. Therefore, this is a significant public health concern. Now, does e-cigarette leads to quitting cigarettes? That's the big question. We are talking of harm reduction today, and that's the evidence. The youths using ants or e-cigarettes are more likely to use regular cigarette later. That's one thing. In a never smoker person, e-cigarette increases the likelihood of experiment with regular tobacco products and increase intention to indulge in cigarette smoking. They also increase the risk of dual use due to lack of awareness about the harmful effects of ants. So if it doesn't stop there, Dr. Sunita Mittal is there, it affects the pregnant woman and the fetus. And it also, there's a risk to the fetus, infant and child brain development. And these are all scientific studies. Now, as we talk about second-hand smoke with the tobacco, similarly, the harm due to second-hand exposure to e-cigarettes is also there, and passive exposure to vapors during pregnancy can severely affect the health of both the mother and the fetus. There are reports of poisoning due to accidental swallowing by the children.
So you have 1 minute.
Yeah, all right. Gateway to nicotine addiction and smoking. That's the final part of my presentation. Youths using ants and e-cigarettes are more likely to use regular cigarette later. E-cigarette increase the likelihood of experiment with regular tobacco products. Also, there is an increased risk of dual use due to lack of awareness. So, electronic delivery system as a tobacco cessation. This is the final slide. Although some smokers have reported reduction in their tobacco smoking, e-cigarette seems to have rather similar or even weaker efficacy as a cessation aids when compared to nicotine patches. So if you compare with the nicotine patches, they are less effective, more harmful. And in a 4-country survey carried in the United States, Canada and Australia, 70% of the study subjects reported to have used ends as a way to obtain nicotine in smoke-free spaces. So what they do is that they smoke, but wherever the tobacco smoking is not allowed, they use e-cigarettes, and so they are actually not using it smoking reduction. So recommendation from the national and international organization, the International Association on Lung Cancer, which is the biggest killer, have said that use of e-cigarettes for treating nicotine dependence even in cancer patients is not recommended. The Indian Medical Association considers ends as an unhealthy and disguised form of tobacco addiction with serious long-term health effects and unfit to use for tobacco cessation. Now, Indian perspective is in India, use of nicotine, an ingredient in any food item, is prohibited under the law. Not because of this. As such, nicotine is banned. Nicotine and nicotine sulfate are listed as hazardous chemicals under the Environment Protection Act. So, conclusion of the expert committee, which met, as I said, based on this is exactly verbatim from that document. Based on the currently available scientific data from the multiple streams of research, the Council recommends complete prohibition of ends or e-cigarettes in India in the greater interest of the protecting public health in accordance with the precautionary principles preventing public harm from noxious agents. So, ladies and gentlemen, let us do end to end, that is, end the electronic nicotine devices. Thank you.
Thank you so much, Dr. Killani. So, moving forward, next we have Dr. Bharat Gopal with us. He's the Director, National Chess Center, New Delhi. Dr. Gopal is a renowned pulmonologist. He's the recipient of the Young Scientist Award from the National College of Chest Physicians, India, and has been awarded the Fellowship of the American College of Chest Physicians, USA. He has written several papers on respiratory diseases and has been instrumental in setting the Department of Pulmonology in many leading hospitals of Delhi. Dr. Gopal will now discuss tobacco harm reduction, the way forward.
First, at the outset, I think probably due to some miscommunication, I was told I have to speak longer. So pardon me if I overshoot the time because I prepared accordingly.
Okay.
Now, I think I'll take off from where the last slide, which Dr. Killani, who has been my teacher, he actually put forward. It was very clear that was in 2019 when this ban came. So a lot of work has been done. 2019, when you do a paper search, you look at studies which would have been done probably by 2017-18, which would actually have data of 2014-15. This is how we all do our research, right? So as you move forward, you'll have to look at that what we are discussing today about harm reduction. Let's not stand at two sides of this part. I think that is a bigger problem which I have realized in my association with this subject or my interest in last 3-4 years, that we either stand on one side or we stand on the other. So we have policy makers, we have some organizations for help self groups, and they will stand on one side, as Dr. Killani was saying, to corner the person who is saying this is not good. But then we have a large chunk of medical professionals who will stand on one side and they'll say, no, we don't want to look at any other evidence. Now let's look at the perspective where actually these things look at. Small disclaimer. The disclaimer at the below, neither smoking or vaping is beneficial to health. Let's get that thing clear for people who are here. Right? Smoking appears to be more harmful than vaping. However, it does not mean that vaping is safe. Nobody, at least from my perspective, I don't stand on that side of the beach and say this is a safe side. Right? It's where and how. We have medicines, we have where we use them day in, day out for a particular individual in the right perspective. I think we have oncologists with us. Chemotherapy has super side effects, but don't we use them where it is required? We do. So where do we actually fit in is that I think should be the base of the discussion of these forums, not standing one side or the other. This was the worst discovery. When you started rolling out cigarettes in millions, cigarette became a finely tuned drug delivery system. I think if I have an inhaler which can deliver so well, probably my patients of asthma would probably be finer for it. It's a bad habit. We have boss of psychiatry and here. So it's a chronic medical condition. Risks, global smoking. I'm going to skip through, just see the slides for whatever work I've put in. But WHO comes out with these reports here, and this is the last one which came out, which it calls it the epidemic. I think it is a pandemic which is already going on. We talk about COVID pandemic, but I think this is a pandemic which has been there where we have shut our eyes and we don't want to look into it. So with so many deaths, millions of people actually suffering, we are talking about long COVID. Why are we not talking about the chronic dependence of cigarettes? The facts, we all know. The pandemic actually opened our eyes that a lot of these patients who were having smoking died more. So this is the last thing which they have come up, is something called as Empower, that how you actually look into the tobacco control measures. And surprisingly, by 2020, one of the best, highest achieving countries of tobacco dependence treatment is India. We all may have our comments on that, but this is what WHO says. Why is smoking still a problem? Right? The problem is that if you look at data across the globe in best of centers, but when you actually percolate it to a larger subgroup, you will find that people who are interested in quitting are maybe 70%, maybe 50-60% attempt quitting. But unfortunately, the smoking cessation rates drop down to something like 7.4%. So despite a patient of mine who has COPD, who is smoking, he wants to quit, the best chance I give him is less than 10%, which is, we all agree, is not very good. So that led to a lot of voice in the community of, can we actually look at tobacco harm reduction as a public health opportunity? I'm not very sure if this forum will agree to it, but I think that is the main thing. And there is going to be disagreement. I picked up this slide from Smoke Free World, and it says that you have, as I said, you will have a whole gamut of people looking into it who will refute the point to probably go on to name calling, and I hope we don't do those things in this August forum. But unfortunately, there is no other aspect that we debate on it. We debate and come to something which is good for the society. Standing at one side probably is not going to help at all. What is harm reduction? We all know. We all practice harm reduction in our daily. It is well established fact that harm reduction has probably found its voice in IV drug users, right? And it actually made, WHO went on to say that probably it's endorsed the use of harm reduction, especially say IV syringes. So why don't we actually look at 1.1 billion smokers and look at the same concept when we can look at say 1.5 or 15 million IV drug users, right? So there are pillars of tobacco control. I think these are more important than looking at the studies. I will present the data which is going to be entirely different than what Dr. Killani said. Prevention of initiation, number one, is the best. We are greatly lagging. The policymakers, the government, all over the world are lacking in prevention of initiation, which means there should be a complete ban on tobacco products. But it gives us taxes, obviously, so there is less said is better. Assistant with cessation, we try, we still do not achieve what we want. 10% is the best. Protection from ETS, again, a lot of work is being done. But is harm reduction one of the pillars? There are books written about it. Sometimes people, my friends who would have not have actually had a look into this aspect of medicine would not believe that there are proper definitions and proper recognition of this tobacco harm reduction. It is controversial, there is skepticism, there are aims of THR which are well published, and I'm skipping these through and maybe we can discuss when we have time, but I'm just getting you to the context. The context is because there is limited success. There is a new environment which is developing, the perception of targets. The tobacco industry is now publicly acknowledging that there are dangers of smoking. So even they are accepting, and probably to their own need, they are now accepting that the smoking itself is killing their own consumers, and probably they have to move away from it. There are new novel products which are now coming, and there are concerns about prohibition of this. There are public health motives, tobacco industry has its own motives, the pharmaceutical industry will have its own motive, and a strategy has to be devised by all the learned people. You quit or die. I think this is what we always tell, chhod do, as a doctor. When we were young and studying in MD, our professor used to say, take the cigarette and put it in the dustbin and tell him, see, do you want to pick this up from the dustbin? So that was something like a cold turkey technique, right? So quit or die was something like this. But can it be quit or switch? I don't know. But that's what the data is going to look at. So there is a large hierarchy of products which can create harm reduction, which are called as potentially reduced exposure products, which I'll just skip through. So nicotine, as Sir said, probably is banned in any food item, but you will be surprised that all potato family products will have nicotine in them, right? The level of nicotine is obviously consumable by humans and it does not cause any harm. The tobacco plants have a different level of nicotine. So mixing of nicotine in food products is definitely not there, but sometimes this is a natural ingredient in many, many food products. It's the route of the uptake that determines the speed of dependence. Am I right, sir? But that is what is going to. So the worst which could happen with this was the modified tobaccos, which are called as light cigarettes, somewhere in 1950s. This was the biggest disaster for the subject of tobacco harm reduction, because this was a sort of a camouflage by the industry to sell more cigarettes. By the time everybody realized, people were hooked on, people had died, and so it was almost a belief that there is nothing called as safe. Yes, there is nothing called as safe, but do we have products which can actually lead to lesser harm? So quickly coming to those things, I'll skip everything about e-cigarettes because Sir has already said. I'll tell you the data. So the biggest proponent of e-cigarettes in their so-called proper protocolized use is UK. Public Health England actually puts it as one of the cessation techniques. But it tells you where. It is for people who cannot quit despite all the efforts or are not willing to quit. So there will be someone who will say, it's my right to smoke, I don't want to quit. So can we offer them something? Right? Or we say, no, we have, everything is banned, so you continue with your normal smoke and die. We will not give you something which can reduce your harm. This is the whole probably thing which we understand. So a lot of data has come in last 2 years in big journals. This is a study in JAMA published from US, where they had a large cohort from 2014 to 19, 5 years of data, where the results showed that actually e-cigarettes, every day the people who are using e-cigarettes experience an 8-fold higher odds of cigarette discontinuation than those who do not use e-cigarettes. This was the conclusion, that these findings support the consideration of smokers who are not planning to quit when evaluating the risk-benefit potential of the. So those who are not planning to quit or who fail quitting are the ones who should be. I'm not saying please start selling this to new people. This is unfortunately, this is the problem which occurs. That either we say we sell it to everyone on the counter, or we say that you don't give it to even those who deserve it. So this is somewhere Great Britain, this is a survey which started in 2010 and 2021 March study. So this is the last one which they've published about the awareness. The awareness has definitely increased. The attitudes have changed. The different products are available, and I'll show you something which is very important, which is the subject which you actually talked to. That if you actually look at the findings from the Public Health England network, it will say that 27% of people use a vaping product to quit attempt in previous 12 months, as compared to 15% using NRTs. Now, let me quickly show you what you said. People do realize that if you look at the perception, the black one is who actually still believe, despite a proper program in place in UK, that this is more or equally harmful. So it is not that they have started believing that these are stuff which are probably of no point and you can just use it as you want. It is not that. The other important thing actually comes in is that if you look at the the randomization of NRT versus e-cigarettes. As sir said that they were, now this is an NAGM article published a couple of years back where it had around 880 participants. The 1 year abstinence rate was 18% in the e-cigarette group as compared to 9.9 in the NRT group. So statistically significant. And not only that, among the participants who completed 1 year of abstinence, the e-cigarette group was more likely than those in the NRT groups to be probably using that same product at 52 weeks. That's almost 80% versus 9. That's a huge discrepancy. I'll not go. See, e-cigarette data, you can find both sides. Asthma, heart disease, good, bad. Different societies coming and looking at the data at different levels. So let's not get into those things, because nobody is saying that you use e-cigarettes to everyone. I'm saying that if a cardiology patient is not able to quit, we know that continuing smoking will definitely cause harm. There is huge data. But now if we replace it with a product which is probably less harmful, so it shows that there is data to show that the impact on the heart and circulation is better than, rather than actually conventional cigarettes. That is the point. It is not that we are not saying A or B. Absolutely, stop cigarette. There is no risk at all. NRTs, again, this is a very nice thing which I wanted to show. This is the whole continuum of harm reduction. So most dangerous are the combustible tobacco products, then chewing tobacco products. The least dangerous will be NRT, because this is just one like-to-like substitution of nicotine. The problem is of acceptance. NRT is available in all our programs, tobacco dependence programs in India. It is available on the counter. What is the sale? You, sir, would know that if you ask companies, there are hardly couple of companies who have come out and they don't even promote that to the doctors. It was very recently I came to know that there's a company which makes lozenges, and I started writing them to my patients and they can't get it because they manufacture but they hardly use it. Probably they give it to only a cessation clinic rather than actually putting it in the public. So what will that smoker do? He doesn't have the acceptance will become. So we will not go into the different products. I think time is short. Finally, the biggest chunk of that white paper was that it will be a gateway to smoking for the youth. This is 2017-18, the data. Now, this is data from vaping in England, where they have already allowed, and obviously they are able to, since Public Health England is attached to NHS, it capitulates all the data from people whom they are being asked to use. So you will find that there are two reports of 11 to 18-year-olds and 16 to 19-year-olds. The prevalence has remained the same. This is 2021 data, last year. This year's data hasn't been published yet. But the data, there is little change in the level of vaping over the last few years. There is little change in the smoking prevalence in that age group. So if this was probably a gateway, then the new smokers should have increased. So probably the smokers who are changing, who are quitting and using vape, the numbers has still remained the same. This is same in the data in 16 to 19-year-old. The current vaping prevalence is around 7.7%, which was same, say 7 to 8 years back. So it's very difficult. Most young people who have never smoked or never vaped, it's around 0.8 to 1.3%. And young people who have had never smoked were current vapers, only 1%. So that's a very, very small subgroup. Most current vapers in children or adults were either former or current smokers, right? So implications are that obviously we have to look at probably newer things. We have to look at how we have a product which has reduced risk but has more acceptance. And I think the psychiatry people will be able to inform more easily that why does a patient feel more satisfaction using an e-cigarette than chewing a tobacco. And I'm sorry, being a pulmonologist, I'm keeping more towards the cigarette smoke, not for the oral tobacco. I don't deal with that. So I cannot give you personal experience, but that is how the things are. So you have to look at a product. Harm reduction will be composite of a reduced hazard with the number of users using it. So NRT is brilliant. Reduced risk, extremely low acceptability and use. So the public health impact would be very small. If you look at snus, which is something which is used in Sweden, again, low risk, more than a nicotine replacement, but high acceptability. So their public health impact has been quite good in their public health studies. So I don't know about e-cigarettes. Can we actually achieve something on those terms with these things? So we have to look at a balance between low risk and high acceptability. This EVALI, for pulmonologists was something which probably pushed us away from e-cigarette things. Last couple of slides. So tobacco control is far from finish line. We all have to look at this whole continuum for my patient and then for the larger society and see where we can fit these in. There is actually a need for new RCTs. Unfortunately, I tried, but there is nobody to fund those RCTs. It's very difficult to find funding which is has no bias, because the pharma companies won't push RCTs for these. After the ban, it is impossible to do it for patients in the clinic. And thirdly, the people who are ready to fund would be somehow XYZ involved in finally selling e-cigarettes or similar products ends, so which you cannot take, because then it's a bias. So I think there is a need for appropriate RCTs. There is a need for appropriate regulation. It cannot be all or none phenomena that we have it or we don't have it. We banned considering we would not be able to regulate. That is what I feel, that the ban in India was because we understand, looking at our population, it will be impossible to regulate. Now, Australia is one of the countries. Last year it went on and actually made it available by prescription. So this is something which we can start. Even if we have a ban, if a doctor wants as a part of a smoking cessation, why shouldn't we be allowed? That is the question. So way forward is policy making. All you are from different specialities. The pillars of tobacco control, those three will stay the way they are. We have to incorporate harm reduction now into those pillars and probably look at striking a balance between these two. It's a teamwork. Tobacco use and fighting these is a team effort. I cannot believe that one person will stand up here and say, I will do it all my own. It is not. Behavioral support. It's a multidisciplinary approach which needs to be. So I'm sorry if I've been trying to be very fast, but I hope I've got the point across that let's not stand at two sides, right? And try to probably join hands. We may have our thinkings which are different, and I think as medical professionals, one thing which is very good is that we are taught to read and then change our thinkings. We have changed our thinking in so many diseases over so many years, right? So I think that should be the dialogue in such forums, rather than having this is good, this is bad, because unless as doctors we are not able to find a one middle path, we will not be able to influence the policy makers. Then this thing will stay the same. So thank you so much, and my sincere apologies, I think, for the miscommunication. So I tried to finish as fast as possible.
Thank you, Dr. Bharat Gopal. I think you showed us both the ends of the spectrum and also talked of the multidisciplinary approach, and I'm sure the doctors would have something to say about this at the end of when everybody speaks. All right, so now we are very happy to have with us today Dr. Jay Kumar, Professor and HOD, Department of Cardiothoracic and Vascular Surgery, Government Medical College, Kottayam. Dr. Jay Kumar is one of the most famous faces of Kerala's famed public healthcare system. Under his able guidance, Kottayam Medical College has become the go-to place for patients across earning spectrums. He is a veteran cardiothoracic surgeon, having done 6 heart transplants since 2016, ladies and gentlemen, and numerous heart and major thoracic and vascular surgeries. Under his leadership, Kottayam Medical College has achieved the distinction of having the maximum number of valve repair surgeries in India. It is also one of the few centers in south of India that handles different types of aortic aneurysms, heart and lung transplantations, and minimally invasive heart surgery. Dr. Jay Kumar is a fellow of several prestigious institutions and societies of cardiology and has authored multiple research papers. So over to you, sir.
Thank you, Loti, for the nice introduction, and thanks, Anil Nair, for inviting me here. Actually, it's a pleasure to see of course, as this is said, the alumni of Aldin Institute here. And actually, looking at as a clinician, as a cardiac surgeon, every day I come across so many patients with coronary artery disease, lung cancer, esophageal cancer, or peripheral occlusive vascular disease. And day you tell that, or the moment you tell that, okay, it's basically one of the most important reason why you get it is smoking. Most of them, 99% of them, just stop it. And on review, maybe just one person comes and say that, okay, hear him say that, okay, he is continuing or something like that. So actually it's Dr. Desai will agree that it's a psychological thing that dependence happens. Like, or even if you look at, say, the COVID pandemic, all the, Kerala is one of the places where you have the maximum alcohol addiction. And we have closed down all the beverage outlets all on a sudden. And the government warned us that the hospitals should be prepared to take care of so many de-addiction, means people with withdrawal symptoms. And ours is a tertiary care center catering to almost 5 districts around, and we hardly get 2 or 3 patients. So it's all depends upon how you look at it, how you go about it. And then now if you look at the tobacco, it is something which kills almost, say, 8 million every year, and we expect it to go up to, say, 1 billion in another 2-3 years' time. So definitely we know that it has to be stopped in one way or other. But as you said, harm reduction, that actually Dr. Bharat Gopal has nicely given harm reduction, how it is going to help. But our worry is like e-cigarettes, whether it's going to be the gateway. Like we may start like drinking, we start with, say, some beer or wine, and after some time now you go into all the other drinks like that. Whether it's going to promote children to get into this habit, and we know in India's background it is very difficult to regulate things. So at the other end of the spectrum, as a clinician, as a cardiac surgeon, I'm really worried introducing less harmful products into the market. Is it going to make more harm than good? And at the same time, if you look at the other substitutes like, say, lozenges, gum and all, it is not at all accepted in so many studies. And if you look at the studies itself, we have data only from outside. As sir was saying rightly, our people, the Indians behave in a different way from UK and US. So we don't know whether if you have the e-cigarettes easily available in the market, our children are going to grab it and use it. But of course, if we have regulations where strictly it is given to patients with a prescription, definitely that is something going to make a difference. So that is all from my side. I feel this is a good discussion, and we have to come out with something balancing both for the public, for the good. Thank you.
Thank you, Dr. Jayakumar. I think you were really on point along with what you said and also the timing. Well, now I would like to invite Dr. Preeti Gupta to put forth her views on the subject. She's Associate Professor Cardiology, Safdarjung Hospital. Dr. Gupta is involved in multiple clinical projects and is the author of several research papers. Her affiliations include the Indian College of Cardiology, SCAI, and APVIC. She's a life member, ICC and CSI. Dr. Gupta will speak on the effects in smoking cessation of non-combustible nicotine products. So over to you, Dr. Preeti.
Helps the environment by killing people. So, and as a cardiologist, I may allow small or moderate amount of alcohol to the public, but I will not allow a single cigarette. So we are really very strict about it, that smoking should not be allowed because it is the main cause of heart disease. And you won't believe that I am getting a child. I call him a child because I see patients of MI of around 40 to 50-year-olds normally. So I would get a patient of 21-year-old who would come to me with a MI just because of smoking. So that should be definitely banned. And this is a lifestyle habits I would encourage that everybody should be keeping a heart healthy diet and a healthy weight, and no smoking and no tobacco. So this is the cycle which is there, that once there's a nicotine absorption is there, there's arousal, tolerance, and there's then craving, and then the vicious cycle keeps on continuing. So, and what are the signs of severe nicotine dependence? Like they're smoking more than 1 pack a day, and smoking within 5 minutes of waking up, smoking even while sick, waking up at night to smoke, smoking to ease symptoms of withdrawal. These are the kinds of patients in which we have to think of the nicotine replacement therapy. So nicotine replacement therapy, We have gums, we have ibuprofen sustained release, we have nicotine nasal sprays, we have nicotine skin patches. E-cigarettes has been discussed a lot, and as a cardiologist, I am totally against e-cigarettes because the vapors which come out of the e-cigarettes, they are harmful, they cause heart disease, they cause cancers, they cause birth defects, the reproductive defects have been seen. So I would be against the e-cigarettes and other nicotine replacement therapy like patches or the transdermal patches and the chewing gums. They may be taken as help to take these people for quitting, because when you start them on these therapies, there are very high chances that they may be in the long run they may end up quitting the smoking. So this is the pattern of delivery of the various nicotine replacement therapies. Like nasal spray gives a brief shoot, and the transdermal patches, although they give a sustained release over a long term, but they are less harmful than any other forms of nicotine replacement therapy. So they may be taken as a less harmful substitute. So best time is to when you start quitting, and I hope the people, they remain quit. So it's because it's not just thinking of quitting, it's important to remain quit. So the studies show that nicotine nasal spray has got the longest long-term effect of quitting amongst the all cessation medications. So there are mouth sprays, gums, lozenges, inhalators, which can help you take these patients for quitting for a longer period of time. And they should be prescribed by the doctor if we want these people to help quitting. And e-cigarettes I don't advise, because they only 2% they do not relapse already, but the cancer causing chemicals and the heart disease causing chemicals, they are harmful, and that's why they have been banned by the US FDA. So the benefits are like that, if the cigarette smoking is causing 7,000, giving 7,000 chemicals, the e-cigarettes would be giving very, very less in comparison to that. But there are reports that they cause a lot of heart disease, they cause a lot of addiction, they cause a lot of cancer, and that is why I am against the e-cigarettes, especially because as a heart disease, a cardiologist is more worried for that. It doubles the risk of heart attacks. And these are the research which shows that it doubles the risk of heart attacks. These are the dangers like the acetaldehyde, the benzene, cadmium, lead, nickel, nicotine. There are so many harmful things in the vapor. So it's not just a harmless cigarette, has got very harmful effects. And these are the chemicals, the long list of chemicals which come out of these vapors. And that's why the FDA has given warning and banned the e-cigarettes, and this is the cycle that they got banned in 2019. And can you get addicted to NRT? So what I feel that when you feel like you are over the cycle of this tolerance and craving, you should stop even the NRT. So it's not the substitute of smoking. You should not just continue with the NRT. You should ask your patient to stop the NRT when the addiction is over. And there are no side effects as such. For the nicotine gum, we advise them to park and chew, because if you just keep on taking one or the other gum again and again, then it would be a constant cycle of giving you nicotine release, and it will defeat the purpose of giving the NRT. So park and chew is the concept. So as such, they are not giving any side effects. Some problems like sleep problems, if they are having, there would be because of the nicotine withdrawal rather than the side effects of the nicotine patch or something. Nicotine patch gives you a very sustained release, so can be taken as a good alternative. And side effects are very less, and we can advise them. They can take support of these NRTs to help our patients quit. So pregnant women and teens, they should not take NRT. And we should choose the right nicotine replacement therapy to our patients: gums, lozenges, nasal sprays, And transdermal patches, they are very good alternatives. And they have to be given only once a day, the patches, so it's easy to use. The pattern of patient's use is also very good, and we should train them how to chew and puff. So I would advise everybody to take help of the NRT, not the e-cigarettes, to quit cessation, to quit the smoking and help in smoking cessation.
Thank you so much, Dr. Preeti, for that detailed account. And I think this would be just the right time for all of us to take a tea break, right? So I would expect all of you to be back here in 10 minutes. Would that be fine? All right.
Gopal, Dr. Jai Kumar sir. We've been talking about cigarettes, and you're talking about the e-cigarettes part of it. It's something sir said about that one, what is the prevalence to the involvement in the cardiology part of it, that ma'am mentioned about it, Dr. Preeti. I think it's it has to be, from the level where it is, we wanted to bring a cracker-free society, if you remember. We wanted to bring the emission of these, the diesels and so forth, and we brought it that it had to come from the manufacturing level, कि उसको बंद ही कर दीजिए, and let us go to the levels where the emissions are less. So I think it has to be really tapped upon the school levels, and that's when it's not going to get percolated not only on the children aspect of it, but also in the families, because they are our biggest ambassadors in the society. So because we have had a group who've used these e-cigarettes, but we've seen the oral pre-cancers getting, the conversion from oral pre-cancers to cancers are much faster than, a person who's just using some of the smokeless tobacco part of it. Because I think it not only induces that it loses its, when these children or when this group start using the e-cigarettes, they lose their appetite too. In turn, there is a deficiency which is developing, there is an atrophy of the mucosa, and I'm sure my colleagues of the ENT surgeons also would probably second to, what has been the studies saying, that esophageal cancers, oral cancers, of course lung cancers. Dr. Killani sir mentioned about the different aspects of the side effects to it as well. And maybe we listen to Dr. Mithil ma'am and about the involvement in the pregnancy part of it, the low preterm babies and so forth. So I think it's a little that we should have in the next group, and a person from an education department who can help us putting some chapters or some aspects at different levels. When we had an exposure to this HIV that we were talking about, बच्चों को sensitize किया, because it's not that now the children were involving in these activities at the age of 13, 14 or 15, as young as 9-year-old, but they're all sensitized why HIV happens, what is it, how the transmission happens. So I think we'll come to, over the years, then we can come to a level that, fine, we are at a win-win situation. Thank you so much.
Thank you so much, Dr. Sunita. And moving ahead, now we have Dr. Atul Ambekar with us. He's the professor, National Drug Dependence Treatment Center, AIIMS. Dr. Ambekar is a psychiatrist specializing in substance use disorders. He's a member of various expert bodies, including UN Strategic Advisory Group on Injecting Drug Use and WHO Expert Advisory Panel on Drug Dependence. Harm reduction and drug policy are among his primary areas of interest. So over to you, Dr. Atul.
Thank you very much for having me here, organizers. In the morning itself, Professor Desai has accused me of being young, but I can assure you I'm working on it. Right. And secondly, Dr. Desai also noted that we, the psychiatrists, are usually the last speakers in any such events. If at all, sir, if we are invited or we are present, right? Because
कह सकते डॉक्टर देसाई वाज द फर्स्ट वन.
यस सर उन्होंने कहा था कि आमतौर पे हम लोग आखिरी होते हैं अगर हम बुलाए भी जाएं तो, particularly for tobacco, in fact, right, particularly for tobacco use disorders or tobacco control policies, etc. It has often been seen that the addiction aspects of tobacco, they are often neglected. For other psychoactive substances, alcohol or other drugs, It is recognized that these are addictive substances, and hence, whenever there is discourse on them, the views of addiction scientists, the behavioral scientists, are taken into account. Not so much in tobacco. For instance, as a glaring example, Professor Killani sir mentioned about the ICMR white paper committee. Many eminent physicians, doctors for all the disciplines were there. The conspicuously absent were behavioral scientists, addiction specialists who understand tobacco or END addiction. So that's the aspect I think has been missing. The missing aspect is that we do not recognize tobacco as being a part of the large family of psychoactive substances which we the human beings have been using since times immemorial. Some of these are more harmful, some of these are less harmful, some of these are controlled more stringently by the governments, by the society, called as narcotic or psychotropics, some of these are not. The reasons are not really scientific in nature in terms of how they are controlled. The reasons are largely political, racial, and cultural, and so on. So one such psychoactive substance is something we all of us used just now. So there is no point in getting too moralistic about it. But that's the unfortunate reality. For a wide variety of reasons, these psychoactive substances are sought to be controlled by the society or by the establishment. What could be those reasons? Because there may be health issues, there may be health risks, or simply on the moral grounds, we do not believe that people should be having fun. People should be using something to change their mental state. Or if at all they are changing their mental state, then they should do so only using those substances which I like. I means the establishment, the government, the society or whoever. And this differs from society to culture to culture. So a combination of these factors have resulted in the kind of policies and attitudes we have towards various psychoactive substances. I'll repeat, I'll just at the risk of repeating what other speakers have already alluded to. All over the world, the management strategies for psychoactive substances can be broadly divided into demand, supply or harm reduction strategies. Now, I will not go into too many details of all of these. What we need to remember is what the supply control strategies, which are actually the most popular despite their very limited effectiveness. Most of us are elite, law-abiding, upper class people who believe a ban means non-existence, right? So in our dictionary, government has banned something which means it simply is not available. Unfortunately, that is not true. A ban effectively means government saying, I am not now regulating this substance, let the criminals, let the underworld take care of it, right? That's what ban essentially means. In Delhi, if I go and purchase a bottle of whiskey, I can be reasonably sure that whiskey it is, and it must be 42%. In Bihar or Gujarat, I can never be sure that what I am buying in a bottle, whether it contains whiskey or not. In Delhi, if I buy a packet of ganja, I can never be sure whether it contains ganja or not. In the morning, there has been a point made that e-cigarette liquids contain a very high amount of nicotine or contains various other kinds of chemicals. If governments were regulating it, governments can actually keep a tab on how much they contain. At this moment, is e-cigarette available in Delhi? It certainly is. At this moment, can anyone be made accountable on what does that e-cigarette liquid contain? No one can be. But do people want to use e-cigarettes currently, people? Yes, they want to. Because they say, if I am not allowed to use e-cigarettes, then I will have to continue to smoke. So any discussion on whether e-cigarettes to be regulated as a harm reduction product category or not should also take into account relatively what we are doing about the combustible cigarettes. This is the interesting parts. All of us doctors, we are made to sit somewhere and discuss over our studies on e-cigarettes, how harmful or how beneficial are they. No one among us is paying heed to what's happening to combustible cigarettes. For last so many years, the prices and taxes structure on combustible cigarette has been largely constant. In today's terms, looking at the inflation, cigarettes have actually become cheaper than they were 2 years ago. Prices of almost all commodities have increased, but the combustible cigarettes, their market has remained almost at the same level. So this is how we must try to evaluate various products and various their options. About demand reduction strategies, we all know they are needed at a much larger scale. Harm reduction is something we have already discussed. It basically means being more pragmatic, since 80% of something is better than 100% of nothing. A rhetoric of a drug-free world, a smoke-free or tobacco-free world will not take us anywhere. People will continue to find some ways to put nicotine in their bodies. Because whether we like it or not, it's the human requirement. We can be smug in saying, मुझे तो कभी ज़रूरत नहीं पड़ी, मैं तो बिना उसके बड़े आराम से रह सकता हूँ. Well, there are some people who simply cannot. And when we need to find some empathy towards those people. There are people who need tea or coffee. And there may be some of those people in this room. There are others who do not need tea or coffee to remain alert, to remain active, and then they try to feel smug about it, you know. आपको चाय पीने की ज़रूरत पड़ती है, देखो मैं तो चाय भी नहीं पीता हूँ, right? So there is some kind of morality judgment associated with it. We need to empathize with those people who say that without nicotine they will not be able to function, they will not be able to survive. Survive in the larger sense of the word, not just being alive. And hence, those are the kind of people who would require nicotine delivery in one form or the other. The point is very valid that the products which are available at this moment for delivering this nicotine may not be totally satisfactory. The products which are being marketed and made in the names of e-cigarettes, they may still have some issues. But if we totally ban them, then all the other further path of research and development on them is totally closed then. If they are recognized as possible alternatives, there is still an option to conduct some studies, to do some more research, to bring about more refinements so that nicotine is further regulated, so that the nitrosamine or other hydrocarbons or other harmful substances in those liquids can be reduced, to make them even less harmful and safer, as it were. But as I was saying, there will always be some people using drugs. They are at the risk of morbidity and mortality, and this is the harm reduction which actually provides us an alternative to look at these individuals. In day-to-day life, we know the examples of harm reduction: condoms, helmets or seat belts. These are very well-known examples of harm reduction. For not drinking, or if drinking, driving instead of not driving after drinking. These are kind of some of the other harm reduction alternatives the society has accepted and in fact promoted and encouraged, which I find missing in case of tobacco, which I find missing in case of, and that kind of empathy, I think, is missing largely from our own profession, the medical profession as well. Perhaps the kind of empathy we have for people affected by cancers or addiction or heart diseases as a result of their tobacco addiction is possibly not there when they are at the stage of just suffering from addiction to tobacco. At that point, the people are seen as just as people with vices, people with some bad habits, not as people who require help, empathy and compassion. So basically, these are various ways in which risk or harm of any substance use can be reduced. You can reduce the method, you can change the product which people are using, or you can simply change the context of consuming that drug and reducing the stigma and discrimination associated with it. So a wide variety of these approaches, these philosophical kind of slants can be applied to use of psychoactive substances, including to tobacco, and one of these could be encouraging, promoting, or at least being more accepting and tolerant of those substances which are of kind of reduced risk kind of products. The needle syringe oral substitution treatment, other speakers have also alluded to, are very well accepted. The government of India's national policies actually officially endorse harm reduction as an approach to deal with narcotic drugs and psychotropic substances. In other countries, there are other kinds of harm reduction approaches are still being promoted and encouraged. For instance, in some countries there are supervised injection facilities where there are rooms available in the nursing staff supervision. People can bring their own drugs, inject those drugs under the supervision of a nurse, so that if something goes wrong, at least their lives can be saved. So we may wonder, oh my God, this is like encouraging people to take more drugs. Point here is saving his life. Point here is not being making a moralistic judgment about whether he is doing something right or wrong.
So can I just request you to
I'm
wind
just
up,
I'm
please?
just wrapping it up now. Historically, we have been largely a tolerant society as far as psychoactive substance use is concerned. For thousands of years, we have been using a wide variety of psychoactive substances, though we do recognize the abstinence as a virtue. We do recognize people not using a psychoactive substance are somehow better human beings. They have more control over their senses, but we still do not have had historically the concept of haram, pap, or punishable crime for using a psychoactive substance. Our constitution does say about prohibiting some products, but which are injurious to health. So constitution does not take a moral stance about using psychoactive substance. It just says health effects which should determine how government deals with particular product. So there are some policies in government which have unintentionally possibly increased the harms of psychoactive substance use, like our ban on availability of opium products has resulted in the burgeoning heroin epidemic that we have in our country, and those are the mistakes which we are right now paying for. Banning e-cigarettes in the absence of not doing much for combustible cigarettes amounts to the same category of unintentionally harm maximization. So we continue to have a poor acceptance, high resistance for tobacco harm reduction, which I think is unfortunate because of various moral, scientific or commercial arguments. But I think we need to sit and find a way around these discussions. What we need as doctors is to work on multiple fronts: appropriate communication strategy, generating evidence and not being shy of examining that evidence, and doing and avoiding all conflict of interest type of allegations. I was particularly happy to see in one presentation a clear disclaimer that that there has been no support from any such industry, and I want to also put this up front. I'll end with this quote by former UN Secretary General Kofi Annan: "Drugs have destroyed many lives, but wrong government policies have destroyed many more." Thank you very much, ladies and gentlemen.
Thank you, Dr. Atul, for that detailed discussion of yours. So moving ahead, we have with us Dr. Sunita Mittal. She's the Director, Obs and Gynecology, Fortis Memorial Research Institute. Dr. Mittal is the former HOD, Obs and Gynecology, AIMS, New Delhi. She has also been a consultant with the WHO, Ministry of Health and Family Welfare, and the World Bank. She has authored more than 400 research papers and several books. Dr. Mittal will now speak on the effects of tobacco use on women's health and their progeny.
Good day to everyone. Thanks, Lottie, and thanks a lot to Anil Nair, Sujna Nair, their team members from Policy Circle, Mr. Rajeshwar, for inviting me here to participate in this consultation, which is primarily focused on harm reduction. I'm an odd one out. You have here oncologists, you have here cardiologists, you have here expert pulmonologists, and of course de-addiction people. And actually our focus whenever we talk of tobacco has always been on cancer, on cardiovascular diseases, on pulmonary diseases. We have not gone beyond that. No doubt, yes, tobacco is causing all these problems. In fact, 4 out of 10 cancers are associated with tobacco use in humans. But I'm a women health expert, and my focus is on women's health. And we actually don't go so much by, of course, mortality is there with cancer, with heart disease, with other things and all. But we wish to focus more so on quality of life. Here is a woman who is bringing forth another life in this world. So we want that is also healthier. With that idea, we did one national consultation on World No Tobacco Day, focusing on tobacco use and its implications on health of women and their children. And we came out with so much of literature is there. many people are still not aware. There is some simmering, some people have mentioned, some experts have also mentioned about that, but I'll just briefly talk to you about, I'm not making any slide presentation, just briefly make you aware and see how we can bring forth some advantage by stopping tobacco, even in this field, when we are not looking at those gory pictures of cancer on tobacco and other things and all. When we look at epidemiologically, so I'll just tell you what is the epidemiology. Gates survey, that global health survey, had shown that 23.8% women use tobacco in India. So it's not less. It's not that most people think. In fact, they say generally men start first, but women quit last. But what was seen was majority of these women were using actually smokeless tobacco. Many other, almost 90% were not smoking. It was gutkas or cannies or misris or all other things which were being used by them. So I'll just briefly highlight what all problems it can cause to health of women and men and their progeny. I'll start with conceiving. Tobacco use has been associated with infertility both in men and women. There is enough evidence that men who smoke have a lower sperm count, have more erectile dysfunction and all, and of course their progeny may also be harmed. Women who smoke have less chances of conceiving, even when there are studies conducted in vitro fertilization clinics that smokers had a lower conception rate compared to non-smokers. So that is one important issue which needs to be taken care of. My always adage is, if you tell a man, don't smoke, you will get cancer. You get answers. Somebody told me, you know, how I started smoking was, I used to fill hookah for my dada. And from there I got the habit. And he lived till 91 years. Why you are telling me I will? But the moment I tell them that you smoke, so chances of your wife conceiving are less and your child having problem are more, they listen to it. You know, they really ask for. So that is one thing which is there. Then we come to reproductive health issues. A woman who is pregnant, there are enough evidences, it causes more miscarriages, it causes more stillbirths, it causes more preterm deliveries, it causes small for dead babies. In fact, I've published a review article on smoking and tobacco use, its ill effects on reproductive, maternal, newborn, child health and adolescent program in our country. We have a very focused RM and CHA program which doesn't bring tobacco use anywhere. We're not even teaching our peripheral health workers that when you are providing antenatal care, please also ask them use of tobacco. Now, when we talk of all these harms which can happen to her progeny, this also doesn't happen only when the woman is using tobacco. It also happens when she is exposed to second-hand smoke. Her husband may be smoking, her father-in-law, her brother-in-law, whom she can't even control. And she's exposed, and her progeny will be exposed to all these risks, more malformations, more low birth weight, more preterm deliveries. All this will happen in her case. It doesn't stop there. These children who are born when tobacco has been used during pregnancy also have more attention deficit disorders, lesser learning abilities and all, and of course subsequently are more likely to convert themselves into tobacco users of any form. And we don't even realize. In fact, there are some communities in Madhya Pradesh where it was observed that stillbirth rate was very high. When we looked into it, why it is happening, we realized that these women were using something which is burnt tobacco, which is called mishri, to rub on their teeth to make teeth shining. None of them was aware of that this mishri has any tobacco in it. They were not even aware of. It's only till we pointed out that you are having stillbirths because you are using this kind of a mishri that people became aware. So, of course, there is a lot of place when we talk of harm reduction to make them aware of all these issues also, not just cancer and not just cardiology or pulmonary issues. That is one thing. So I don't think I want to say much. E-cigarettes, of course, Dr. Desai also pointed out, there was a study in England in pregnant women. In fact, they have very good statistics keeping and all, and they found that when women were told that pregnancy can be harmed, there was almost 52% reduction in smoking rate. Some women were concerned, I'm already 2 to 3 months pregnant, harm has been done, why should I? But when explained that whenever you stop, it's going to be good, they did stop, only 12% remained smokers later. But those who converted to e-cigarettes to reduce harm, they became more smokers after the delivery. So it is not that e-cigarette weans them off combustible cigarettes and all. And of course, problem in our country is going to be very, very different because it's not e-cigarettes, it's not even other cigarettes and BD, which is affecting these women's health. If in fact, we have also observed that women who are working with BD rolling industry, where they're indirectly having have a higher prevalence of cancer cervix. So that is also a problem in cigarette industry, which is never even pointed out, which is never even thought of. You know, all tobacco control will focus mainly cigarettes, put tags, put such gory. They will not even put the same images on BD packet. And when in India, I think 60% of smokers use BD or hookah or other things, even smokers, forget about non-smoking. So these are the things which I really wish to highlight. And of course, whatever harm reduction policy circle is planning is certainly most welcome. But I would definitely like to give a message, conclude by saying one line that since we know now we have enough data that progeny is affected, women's health is affected. Even people were worried about SIDS, sudden infant death syndrome. Why the baby is suddenly dying. And then they found that 30% of SIDS were occurring in women who were smoking. So this is a very, very important cause, what is happening. So as we know that smoking or tobacco use adversely impacts the health of women in all stages of their life, starting from birth to even senescence. They have early menopause, then of course postmenopausal cancers and all would always be there, which is the main focus. But there is a growing body of evidence that smoking causes preventable harm to women's health. It is definitely preventable, with ill effects being most profound during pregnancy and immediate postpartum. So that is one area where we really need to focus and where probably e-cigarettes will not be, and we have to make them aware that many of these smokeless products which they are using are actually containing tobacco. Smoking may not be that prevalent in our country, but other smokeless tobacco use and of course about second-hand smoke or passive smoking has to be taken care of. That husband or the family has to be told that if she is carrying, kindly refrain if you want a healthy grandson or a granddaughter, even if you have, then only they can have it. I would definitely, in light of all this evidence, would want to recommend that it should also become part of our tobacco control program. Messages focused on reproductive health issues and all. Rather than that, what has been happening, earlier we had advertising macho images of men smoking, you know, and now there are commercials which glamorize that smoking women are more fashionable, they're more modern, it helps to control their weight and whatnot. I think some curve has that also is very important for harm reduction. because that is also, they are listening to all those things, they're watching all these things and all. I think we really need to focus and also train our all MNCH workers that please screen everybody who comes to you with any infertility or reproductive health problems also for tobacco use history. Not just smoking, but tobacco use and passive tobacco use history.
Thank
With
you
this,
so much.
I thank all of you.
Dr. Sunita Mittal. Well, we have on our panel Dr. Sunil M. Raheja. He's the former medical superintendent, GB Pant Hospital, New Delhi. Dr. Raheja has been the Director General, Health Services, Delhi Government. He has also worked with the Central Health Services, Ministry of Health or Family Welfare. Dr. Raheja will now speak on the harm reduction clinical evidence. So it's over to you, Dr. Raheja.
Good morning, everyone. First of all, I pay my sincere thanks and gratitude to the organizers for organizing such a brainstorming session, I will say, because this topic is quite challenging and you cannot say one way or the other which way is right. So fortunately, we have the experts from all over India, so wish we have a way forward. I will been listening to all the speakers and I think most of the discussion points have been covered. I will start my discussion from the grassroots level and with my practical experience. I have been the member of the Delhi University Smoke Free Initiative. So we happen to deal with students, with people around in the hospital, in the campus, in MAMC, in university areas. We came to know that the basic thing is that we have to catch the teenager group early, because the data shows most of the people start using tobacco in teenage group. Average age is 17 years. And once they adopt to tobacco use, smoking, it will stay with them for their life. It will stay forever. Another data shows if you start smoking in 30s, 40s, it is still easier to give up. So if you start at that age, it becomes even more difficult. And India has a different problem, as we have been discussing. It is not only the cigarette smoking, but it is the gutka, bidi, hookah, other forms of tobacco. And if you see the data in the last few years, the tobacco use has been increased much more by the females than males. I think Lottie and we had a program on Lok Sabha TV on this. So females are getting more towards tobacco use than males. And as Dr. Mittal said, in females, the tobacco can do more harm. Starting from infertility, and once they get pregnant, IUGR, stillbirth, and all sort of problems, and there are studies that it affects the DNA also. If we see, tobacco in general affects us from top to bottom. It will burn your body to ashes, like graying of the hair, wrinkling of the face, early aging, smoker's lips, loss of taste and smell, then cancer of the mouth, lungs, COPD, asthma, high blood pressure, coronary artery disease, heart attack, stroke, cardiovascular diseases, acidity, cancer of the colon, stomach, and in males, erectile dysfunction. And I think once you take up this point with the younger people, those who are teenager, they are very sensitive about it. This is where we can hit the hot gun. कहते हैं ना लोहा गर्म है तभी वहीं पे लगाना है. तो this point have, and I don't know why people are not discussing on these basic concepts with the youngsters. You tell a youngster, यार ये तुम्हारा erectile dysfunction को affect करेगा, you will end up in a different sort of problems. Like, then they okay, yes sir. So we have to deal with students. We have sessions, talks, and we have to basically persist with the our lectures and follow up these students, because they again take up smoking otherwise. Then it will decrease the blood supply in the legs, Berger disease, intermittent claudications. It decreases your stamina, cardiorespiratory functions, your energy to work. And smoking or tobacco actually increases your stress and sympathetic activity. No one knows it basically. These are few myths, even the youngster didn't know. Sir, हम तो टेंशन में रहते हैं इसलिए पी लेते हैं. अब they don't know कि this is otherwise going to complicate their blood pressure, heart rate and anxiety parts. So as we have been discussing, earlier it was thought in 1950 that tobacco causes psychological and social smoking, aspect. But later on we came to know in 1980s that it is the addictiveness of the nicotine which is to be addressed, because nicotine is going to kick your heart rate, blood pressure, feeling of alertness. So beside that, no one ever talked about, as Dr. Desai said, 4 to 7,000, 4,400 different chemicals which affect our body, like tar, benzene, benzopyrene, hydrogen cyanide, the gas which kills, which was used to kill the people. It is so dangerous. And then carbon monoxide and carbon present in the smoke, which can cause COPD, asthma and other diseases, respiratory allergies also. So once we come to this, as I said, it is a difficult topic to talk about because harm reduction has generated a lot of controversy already. Earlier it was decided that you start with light, ultra light brands, and only after 50 years we came to know that epidemiological data has shown that they have not shown any benefits. At the same time, when we came to know that it is the nicotine which causes addictiveness. Hence, it is not only the psychological, social drive, but it is the pharmacological action of the nicotine which also needs to be addressed. So, we talk about the modified smoking behavior by going to the low nicotine cigarettes, but at the same time, you come to know that now the person is smoking more number of cigarettes. So the other potential chemicals which were there, that is consumed even more. So overall, smokers who are willing to quit are unable to quit because of the addictiveness to the nicotine. And this is where we have to decide. But the studies shows that there is no safe level of smoking. We cannot say that this is safe, this smoking is unsafe. If you smoke 5 cigarettes, it's okay. If you smoke 10, you will be harmed. So once we are in that controversy, we need to have a preventive strategy. And as we know, educating the people at an early age, as I already said, catching them early, and we need to have a multi-pronged holistic approach. In that, I will say the behavior change is very important. Willing to quit. Because, we have put the fine also. Earlier we started with a fine of 200 if you are found smoking in the campus or university areas. And we ended up in a lot of controversy, Every day I go with my team and then catch some student, and then lot of, half an hour, 1 hour is wasted, and ultimately it goes here and there. And we had done some challan cutting and all that, but it did not pay off, because then the students will go inside the bathroom and smoke and come out. वो मुझे देखता था दूर से और सीधा इधर या उधर, तो that will not pay. Ultimately we have to give up that चालान वाला फार्मूला. हमने पूरा प्रिंट करवा लिया था, रसीद भी, everything, and our team will go around and check people around. So that did not click. After 6 or 7 months, we ended up in lot of jhagadabaji, ladaibaji. So we thought it's not going to click. So ultimate solution lies behavior change, and we have to give them the support to quit, like nicotine patches are available, then bupiron on other drugs are there. Then it has to be working at the family level, teachers, parents, peers, and community levels, like areas like railway station, bus stop, seminar rooms, smoking is not permitted. At the same time, we need to address the psychological aspect of the person, like anxiety, stress. So we had organized yoga sessions in MNC, to be very honest, with Shri Shri ji and that Guru ji. So we had a different, multi-pronged strategy. Still, I will say it will take 4 to 5 or even 6 attempts to give up smoking. It's not that easy. People say giving up smoking is very easy because I have done it so many times, so you don't worry. So it was like that. वो कहते यार मैंने बहुत बार छोड़ी है, बहुत आसान है छोड़ना. तो it was like that. So if you can imagine कि self relaxation, psychological issues, their family issues, other issues, friends and peers, and you have to tell them कि भाई आपको ये देखना है कि you want to choose between health or illness. You want to have good stamina, good strength, vigor, vitality, what else you want. So I think even females are very sensitive about all these issues, but I think we need to have a approach which is multi-pronged at the grassroots level, and it needs persistence. Thank you so much.
Thank you, Dr. Raheja, for pointing those issues. Well, now I would like to invite Dr. Pavan Gupta, Director, Surgical Oncology, Max Institute of Cancer Care. Dr. Gupta is a well-known oncosurgeon based in New Delhi. He is the Director, Surgical Oncology, Max Institute of Cancer Care, East Zone, and the Founder Director of iCan Care, an innovative enterprise for cancer care and rehabilitation, and Tobacco Cessation Intervention. He is also the National Convener and Master Trainer Tobacco Cessation course, accredited by Gujarat University, and the National President of the iCan Win Foundation. Dr. Gupta will be speaking on the topic harm reduction or complete cessation. So over to you.
Thank you, Lottie, and thanks Anil and Sajana and Rajesh. Actually, I come from the background that I am an oncosurgeon, and I have been seeing patients of all types, whether it is smoking or smokeless varieties. What I want to just add here is that what we had seen, like in 80s and all, we had seen more of smoking varieties, which was very well written. It is injurious to health. We are seeing more of lung cancers and esophageal cancers and the stuff. But addition of non-smoking varieties had actually increased our more number of diseases. Right now we have got more of oral cancer, and we are the world leader in oral cancer. And probably a lot of doctors now come to see us how we treat our oral cancer patients. Earlier we used to go to the Western world and just check. But now we are the masters. We are training them oral cancers. By adding another variety, that is the e-cigarettes, and we are probably increasing more number of diseases to our which is already existing. I come with that clear thought, and that is that या तो आप कुएं में हैं या कुएं के बाहर हैं. Either you are taking tobacco, you are not taking tobacco, whatever the varieties. But at the same time, I'm also looking at what Dr. Desai says. We need to have system set for tobacco cessation. That is how to help a person quit tobacco. That is the system set. Yes, that may require NRT. NRT is also a form of harm reduction. That may require NRT. Yes, we need to give NRT to our patients to help him to completely quit tobacco. That is the goal that we need to have. It's not that कि चल भैया चलता रहेगा, चूर लेता रहे, फिर छोड़ दिया तो चल फिर सिगरेट ले ले, फिर चल तंबाकू ले ले. Our goal is very clear that we have to use NRT for the purpose, with the goal that this person is going to quit tobacco over a period of time, maybe 3 months, maybe 6 months, or whatever. We have to fix our goal. Yes, this is the. So here what I say, we need to have NRTs. NRTs doesn't mean only particular varieties that is being means put to the youngsters, which is being impact messaging is being done for these varieties, which is making these youngsters feel that oh, they are if they do not take that, or if they are not having that, then they are not in the peer groups. No? So we should not be advertising that, or we should not be putting it forth, and all the people who are actually advertising such things are actually putting patients or putting people to take suicide, right? So they are, in one way, they are putting people into risk, and they are actually, these children will ultimately die because of tobacco. I put it in very clear way. I have made a simple balloon in our system that what I say, there are 5,500 people entering into that balloon every day. That means 20 lakhs per year. 3,700 people existing this balloon every day. That is 13.5 lakhs per year. And how they are existing? How do they exit this group? By dying. And painful death, either by cardiac, respiratory, stroke, or cancer, or 200 diseases which have been defined, whatever sir is saying, impotency, whatever, they are suffering in their life. So we have to work together into that factor that yes, we can bring that change, and that is where we have to work, and that is where I come with my experience. And let me put it, my journey as an oncosurgeon started in tobacco cessation because of one sentence that was told by me by one of my patients. डॉक्टर साहब आप तंबाकू छोड़ने के लिए बोलते हैं, कैसे छोड़ें ये तो बताते नहीं. And this is the problem with all the clinical people who are sitting here or who are not sitting here. But the problem is we are doing quackery of tobacco cessation. We are actually not entering, we are not actually doing dedicatedly, we are not doing tobacco cessation. If we do work dedicatedly, we are busy clinicians. A cardiologist who has a busy clinician, she can't put her time for tobacco cessation because it needs dedication. I'm an oncosurgeon. I don't have too much of time to put it, man. So what I did, so I started a tobacco cessation center at Max Hospital, which is a dedicated center. We have trained people, and it's not a psychiatrist there. We have a dental surgeon who are working there. We have trained them, who are dedicatedly working for tobacco cessation, and we are getting results. We are getting patients being referred from all the departments, whether it is cardiology, pulmonology, gynecology, orthopedics, ophthalmology. Every department is referring patients to that center who is dedicatedly working, and we are showing results. The results are there, and that is what we are working on, and means the results are very high. And let me put it, my patients who come with cancers, if I say them that please quit tobacco, they will quit tobacco. If I don't say, अच्छा ठीक है तंबाकू छोड़ देना, without emphasis, चलता है. He's not. But with emphasis, with work, it will work. So we have started, I'll just in short, we have started a Save the Youth program. Save the Youth program, that is our campaign. Save the Youth consists of SAVE. S is for sensitization, A is for assistance, B is for volunteer training, and E is for enforcement. So S consists of three things. Be smart, do not start. We have a book for that. Be smart, do not start. जागरूक रहें, प्रारंभ न करें. And we have distributed 1,65,000 books before COVID, and we have been now doing it digitally across India. And we are going to the schools, colleges, and it is a dedicated program where we are training volunteers to go and do it. It's just not possible for me. I have myself done 647 schools. Then the second part is win over tobacco is easy. That is what we want to put it to the people. If we do tobacco cessation dedicatedly and properly, yes, it is possible to quit tobacco. And those who are saying that it is not possible to quit tobacco, let them redo it. That is, yes, it is possible, and we have to work on it. It may take 5 times, 6 times, yes. And probably by the time that person has come to me, he has already had 5 times or 6 times. So when we work with them, it becomes very easy for us to work, and they do quit tobacco. Third is be careful and fearful. This is another work that we are spreading out amongst the people who are not taking tobacco, who are not smoking, who are not taking e-cigarettes, who are not taking anything. Be careful and fearful with the people who are taking tobacco around you. Do not be with friends with them. Avoid them. People will say that we should have empathy towards them. Arey bichare le rahe hain, bichare phas gaye. Bloody hell, if they have taken, bhai, you are not included in my society. Get out of it. Right? That is where we have to work. We have to create that feeling in every youngsters that my friend cannot be a tobacco user. If he's a tobacco user, he's not my friend. That's it. The second is that we are working on assistance program, assisting to help people quit tobacco. We have done extensive research on that. We have even made various groups of the patients who are high metabolism, low metabolism, or neutral metabolism, and how to intervene for each of the patients with NRT, with platinum models, with NRT, without NRT, with varenicline. Varenicline, no one is talking about varenicline, which is available in India, and it is a wonderful drug for our patients to quit tobacco. We can help them. A lot of our patients are on varenicline. So we have started an app, a software which is protocol based, how to help a person to quit tobacco. We have started a national quit line number, which is the first private quit line number in India. We have started that, and we are getting calls across India, and we have started a virtual tobacco cessation program where we are getting patients across India to help them to quit tobacco. This is the V is the another thing. I'll just take 1 minute more. V is another important thing, that is the volunteer training. What we started is we got with Gujarat University, we started tobacco cessation certificate programs, how to train doctors. We are training doctors to help quit tobacco. We made it in 2 steps. That is, one is the specialist who will do the tobacco cessation. The second is the orientation, that is like clinicians like us who do not have the time to actually go in deep into, but we need to understand tobacco cessation. हम लोग खाली superficially बोल देने जाते छूटता नहीं है, चल तू चला जा, that will not work. We have to be part of it. We have to work. All the clinicians have the moral duty to work for all the patients, because all of us sitting here will come across tobacco patients who are come with tobacco, right? So we did it in 2 steps. That is orientation, certified tobacco cessation specialist course, and the second is the orientation course in tobacco cessation. And this is all Gujarat University certified courses. We had worked extensively in that to make it a very protocol based training program. Third is basically enforcement. Like in university, if you want to enforce, Dr. Sunil can't go every day and do it. We can't have. So we created tobacco marshals. Like I'm putting a tobacco marshal batches. I have got a cap of tobacco marshal. We started a tobacco marshal program where we started training the teachers, the students. In a PSU, we started training the HR to become tobacco marshals within the group. And specifically, we are actually targeting the women as tobacco marshals. Because of whatever Madam has said, we have already noted that tobacco marshals are influencers in the society who work closely, because they are within that place, within that university, within the school, within that thing. So that any person who is taking tobacco will be immediately taken care, and if needed, they can be sent to the tobacco cessation centers to be trained. So just 30 seconds.
We'll have to wind up.
30
please.
seconds.
Okay.
So what we are actually doing, we are into the training. Now, after the successful tobacco cessation center at Max, we are looking at setting up such centers across into various other hospitals so that this can successfully work and successfully we can work it out. Last year we trained 705 doctors. This year we are training 220 doctors. We have a target and we have been funded for that. So thank you so much. I will not take it further.
Thank you so much, Dr. Pavan. And I'll request the other speakers also to kindly adhere to the time limit, please. And now we have with us Dr. M.C. Mishra, former Director, AIIMS, New Delhi. Dr. Mishra is a trauma surgeon consulting with several top medical institutions. His areas of interest include improving trauma care in India, minimally invasive surgery, surgical training, and cancer research. He is the author of over 200 national and international research papers and 4 books. Dr. Mishra is an honorary fellow of the Royal College of Surgeons, fellow of the American College of Surgeons, and a member of the French Academy of Medicine. So I request Dr. M.C. Mishra to kindly assimilate what has been discussed so far and present his own points of view on harm reduction.
Thank you, Lottie. Thank you, Anilji, Sanjana, and Rajeshwar, for having me here to learn what is going on in society with the smoking, with the tobacco chewing, because we have been experiencing for half a century, and even before that, when I was maybe 7-8 year old, my mother-in-law of my eldest sister, She was chewing tobacco, Manpuri tobacco. I don't know how many of you heard, nobody talked about, even Pavan didn't talk about the Manpuri tobacco. That was famous for oral cancer. And a lot of work was done at Agra, Medical College Agra, ICMR, about that. And she had this cancer, and she died of that cancer. One day in outpatient, there was Manoj Pandey, was his name, member of parliament, son of Kedar Pandey, a politician from Bihar. And he had an ulcer on his tongue. And he was a ardent pan chewer, tobacco chewer. And I took a biopsy in minor OT, and it turned out to be squamous cell carcinoma. Narasimha Rao was the Prime Minister. Since he was a member of parliament from Bihar, an important person, so he was sent to UK for treatment. I am talking of, you can imagine, 91 to 92. And he died there very soon. Within, I think, 6 months, he succumbed to that oral cancer of the tongue, cancer of the tongue. The third person was a community medicine person. I think nobody is alive today, so I can take their names. Dr. Devki Nandan. He was director of National Institute of Health and Family Welfare, and he was an ardent tobacco chewer, pan chewer, and he developed that, and he also succumbed to that. Another person was in RML hospital, again a doctor, and Subhash Mishra. He succumbed to oral cancer, and like that many. I have seen young lives have been taken away because of this. One of my very close friends, as Pavan is saying, is very true. I developed hate for tobacco because he was a medical college friend and he was addicted to smoking. And at that time, since we didn't have money, so he was using Charminar, chain smoking. When he quit, after many years, once he got coronary artery disease. That's what I was saying, that people do, you ask people to reduce weight, they say, sir, हम तो एक ही रोटी खाते हैं, हमारा वजन तो कम होता नहीं है. As soon as they get MI, myocardial infarction, heart attack, suddenly the weight will come down. Same thing happens with tobacco also. Now we get this Burgers patient, in and out, Dr. Raheja was mentioning, that we ask them to stop, and this is, most of them are BD chewers, BD smokers. They come from rural area, and we'll ask them, बीड़ी बंद करो, एक भी बीड़ी नहीं पीना है. कहते हमने तो छोड़ दी है, कब से छोड़ी है, अब 3 दिन हो गए. So this is the usual story of these quit smoking, those who quit. So it's basically, tobacco is a systemic disease. You cannot dissociate, as Dr. Raheja was mentioning, from head to toe. Any organ of the body can get affected. All cancers have been associated with the smoking, every cancer practically. In India, we also use the phrase that 80% cancers are related to tobacco, and it is preventable, like oral cancer, aerodigestive cancers. Okay, not all cancers, lung cancers are preventable because they are caused by even pollution. Pollution is like smoking. Like our housewives and women housemakers were using chulhas, which is now Modi ji has revolutionized by giving them gas connections. So this is a way forward. Of course, this will also help in reducing this, but pollution is also, it's a double whammy basically. Smoking and pollution put together. And we used to have a fight with one of my anesthesia colleague in OT all the time. I mentioned last time also. If you remember, Dr. Sunita Ravi Batra was smoking. So we used to fight. You can't smoke in changing room. If you have to smoke, go on the rooftop. Please, we don't like. And I am basically a little bit allergic to smoke also. So I used to get very uncomfortable. I can make out from a distance that somebody has smoked there. So, and we used to have that. And I think that is very true. Empathy at some point, but you have to tell these people, if they are close to you, because you want their welfare. And that's why I agree with Pavan that that has to be done. So what Dr. Desai started with, basically his experience, and when I think Anilji, when you shared, Sanjana ji shared all the publications, I think more than 60-70% were from Dr. Desai, those publications. So he has extensively worked in this, but I think practical approach is needed, and personal involvement is what takes anything to succeed, like Pavan, what he is doing. That is very much needed, and we have to have team, because one person can't do anything. It has to be replicated, what Pavan is doing. Train people, because I don't know what to tell these people how to quit smoking. I have spent half a century in this profession, but if I have to counsel someone how to quit smoking, I don't know what to tell them, how to tell them, how they can be. We just tell them plainly, stop, quit. Maybe we are undertaking you for an operation, so stop for 4 weeks, and they will restart after the operation. And many a times illness does help in quitting smoking. A lot of people quit, they sustain that, but many of them, they come back to use tobacco. So I think what Dr. Nimesh's point was that don't try to achieve excellent, so that good becomes a victim. I think that was a very important point, and we all have to continue with our efforts. And even if we can do a little bit contribution, we should accept that, because we can't revolutionize the whole world in one go. Dr. Killani, I think, enlightened us about his ICMR committee and the white paper, and he very clearly mentioned that the impact of these electronic nicotine delivery systems is also equally harmful. So we cannot say that it is less harmful, more harmful, but question is the ban helping or it is harming? We don't know. I think that is where the challenge lies for all of us. Dr. Bharat Gopal very extensively covered, and he said there are only 10% chances that we may succeed in let people quit smoking, and and we have to be. He mentioned something about tolerance. So I think that is and preventing initiation, assistance, all those things, and reduce risk that will lead to. So, but in theory, of course, we all know that has to be done. But how much we are able to do, how many people are able to do, I think that is the challenge. We can talk hours and hours that what are the harmful effects. We all know. It is nothing new. It's not a rocket science that tobacco is a systemic disease. If we smoke, we chew, it's a systemic disease. Dr. Jayakumar very briefly mentioned, as I am a clinician, so he's a clinician, so we see the end product of tobacco use. And that is where I have seen that as soon as they get heart attack, like my brother-in-law, my wife's brother, he was a smoker, heavy smoker. So he got MI in, I think, 2006. And his son drove to him from Parvanu to PGI Chandigarh. And we were in Cochin at that time, so he was saved. Dr. Talwar was fortunately there, so he did stenting on him. And he has reduced but not stopped even after that. So he still has 1 or 2 every day. So that kind of a craving remains for some reason or the other, we don't know, and that's why the research is needed in this direction, why people are not able to do that. Then Dr. Preeti mentioned about non-combustive, and again, she is for ban, but I think we have heard that ban always doesn't work. That also we know that. So that is something, and I think in one of the dental meetings when I attended, they said sugar is new tobacco. That the phrase it is used in dental, this sugar is new tobacco. So that is also we have to remember. And so I think then Dr. Sunita Gupta mentioned, and again Preeti would also see the patients towards the end of the smoking harmful effects. And so all of us experience that. We see burgers, we see cancers, we see cardiac problems. So any system of the body is affected.
So may I request you to wind up, please?
And Atul, naturally, although he is also not for ban, and he extensively discussed psychoactive substances and how we can do that. And he said we must have empathy also. So maybe I think it's that also is an approach with some which can be used to reduce for harm reduction. So we can have multiple strategies basically. Dr. Sunita Mittal extensively talked about the harmful effects of tobacco on the women, the fetus, the neonate, and that also is important. Dr. Raheja again extensively mentioned the campus, if we can make tobacco free, not easy, but I think, because there are a lot of incentives for smoking. And then Pavan shared his experience. And I think, I consider that he is doing great work, because I have experienced with him on his programs. And I think that is the way forward. And as he's saying now, he's replicating in other hospitals, and that is what is needed. Every hospital, and I think from policy circle, you can take this recommendation to the health ministry that we should mandate from NMC and also from Ministry of Health, every small or big hospital should have somebody who can counsel these patients. And you have these psychologists, you have at least somebody there who can counsel and guide them where they can go and get de-addiction, or if they want help, at least those who want help, if they are coming to these hospitals. Because today, if you ask, many hospitals will not have any kind of a support to support these people how to quit smoking if they really want that, they want to do it. So I think that is something which I would summarize, that it's a systemic disease and it's a social problem. And as I think mentioned by Dr. Raheja, very clearly, it's a teenagers. And what we are talking about mainly the urban, maybe lower middle class. But if you look at these poor children, rag pickers, they are a problem, because they smoke this tobacco, bidi, whatever they can lay hands on. So the problem is much bigger than what we actually can see. So it's a real problem, and we have to have multiple solutions for it. One solution will not work for everybody. Thank you.
Thank you so much, Dr. Mishra. I think you really assimilated everything what everybody said beautifully. Well, friends, we are privileged to have amongst us Dr. Madan Gopal, Senior Consultant, Niti Aayog. Being a public health professional, he has more than 30 years of experience in working on issues related to health system reforms. He has worked on a variety of projects in programmatic, technical, and operational areas. So I would like you, sir, to tell us what your take is on this.
Okay, thank you, Lottie, sorry. And thanks Policy Circle for giving this opportunity. Being the last speaker, sometimes you stand between the lunch and the participants, but I usually take the advantage, because if the person is sleepy, and I can directly enter into the subconscious and work my way through and implant all the things. That's not a big thing. Okay, having said this, one of the important things which has stricken, I think you might also noticed, that have you find any smokers in our group now? Nobody has. I have not seen anybody going out and taking a nicotine break. That kind of shift has happened. In any of the previously, when we used to have conferences in the IICs and the Habitat Center, people used to go out, walk out, and they used to have nicotine breaks. And that break is not there, and that's a kind of cessation efforts, and that is yielding results. Now you won't be finding people who will be smoking. We have got a lot of results and encouragement in seeing the cessation of the smoking tobacco. It is very difficult to find people smoking nowadays, because, as you have rightly mentioned, you have to instigate your anesthetist friend saying that you go out and this. Now it's not required. Most of the government institutions, they are smoke free. institution. If you want to smoke, you have to go out of the institution and have to smoke. That kind of change has happened. I am not talking about the harms and the benefits of reduction in this. We have to have a balanced view. But if you look at the effects which the tobacco is having, tobacco and the nicotine products it is having, that's very immense. I am not talking about the economic impact, the direct cost and the indirect cost. There are plenty. It goes into 1 lakh crores per year, the direct and the indirect cost. Are we ready to bear that thing? If we have not done something, 80% of the cancers are coming from your tobacco. Do we have enough tobacco? Last time also I mentioned that do we have enough beds to cater to the needs of the cancer patients? No. So prevention is the strategy. If we talk about harm reduction is not substitution. Harm reduction is how Dr. Pavan Gupta has mentioned that is harm reduction. We have to see that how we take it to the next level in following this kind of harm reduction strategies. Harm reduction is not substitution. That should be very, very clear. If you see, one of the Oceania nations, that is Australia and they are now saying that the tobacco you can only have on prescription basis. But we have to focus that how we reduce the accessibility to the tobacco. The school children, if you do a survey, last time also I mentioned that school children at the age of 10 years, 11 years, they would be having tobacco leaves in their pockets. You have to see that. Apart from that, Dr. Sunita ji has rightly mentioned, I was just discussing with few of the members, saying that you see how you have seen a sprung of the infertility clinics in tier 2, tier 3 cities. Previously they were only restricted to tier 1 cities. The cost of infertility is very high. Apart from that, madam, it's quite valid thing. That means until you console that patient that it is affecting the sperm count, your fertility and your progeny, people will not do away with the consumption of the tobacco. Tobacco ban is required. It's not that the banning will result in loss of livelihood and other things. Though government is making efforts in the direction of crop diversification, you might have seen. When earlier this nicotine, that opium cultivation used to happen in the early 1900s. You see that the majority of the farmers were into this opium cultivation because that was a cash intensive crop. Once the regulation started happening, now you have regulated crop growing and only 2 centers that is processed, that is 2 districts they are processed. Though the grey market would be there for any of these such activities, grey market is already there. But you see, the issue, people say that if ban is there, what will happen to the farmers? But you see, when the crops were diversified, they could earn more than what they were earning when they were doing the opium cultivation. So efforts are to be made in that direction also. Apart from that, the people who are working in the agriculture fields, the green tobacco sickness is also there. People are not realizing that that sickness is also there. As Raheja ji has pointed out, it can affect from head to toe. We have to see that do we want that kind of person in our society? We have to follow the approaches. That's a small effort. And many such efforts would be there in the country. We have to make it as a Jan Andolan, taking clue from what Dr. Pavan Gupta ji is doing. That is harm reduction strategy from my perspective. And we have to see that how we make it as a people's movement so that people usually know the harm effects of this tobacco and they seize it. Cessation is the answer because I have been hearing, I'm just taking my personal example, my mother used to say that the father was a chain smoker. He used to, a cartoon of this cigarettes used to come. At that time, Charminar was the famous cigarette. And he used to consume around 3 packets of Charminar in a day. But I have never seen him smoking. Because he had a bet with his friend saying that I will quit smoking, and he has quit the smoking. It has to be abrupt like that. It cannot be saying that I would be having substitution of something else. There are many other examples also. People have quit smoking and this. I'm not talking about morality. If you want to do this, let the ban would be there. You see, the ban was there, cigarette smoking, we could not see. That kind of change will happen in the society. The harm reduction has to happen, what people have been doing, and we see that how we follow in that direction. One of the important thing is including the history taking. Sunita madam has rightly pointed out that when the ANC care is happening, we should take the history of tobacco consumption, because that thing right now in the operational guidelines is not there. We have to see that how it is built into the operational guidelines. That's the biggest takeaway for me from this interaction, that how to build that into the deliberations when our peripheral most workers are interacting with them. But we do have acts. The FSA's Act as the Gupta Act. Gupta is for the regulation of the cigarette and products, and the food and safety standards. It mentions that Killani ji has rightly mentioned that it is taken as a food. Once it is interpreted as a food by the Honorable Court, that any form consumption of nicotine would not be acceptable, and you would be seeing lot of bans and other things. That's a matter of the Honorable Courts to decide. But for the harm reduction, the strategy, we have the answer. It's not just only replacement. Replacement would be one of the methods, but the strategy which Dr. Pavan Gupta ji has mentioned, at least we see that how it is take to the next level. I will stop here. Thank you very much.
Thank you so much, sir. Dr. Killani, now that you've heard all the discussions and everything, I would want to know how you want to react to this.
Thank you so much. Thank you for giving me that chance, and I am happy that I was able to generate a discussion. So I have got few points to say. I don't believe in fait accompli, saying that whatever you ban would lead to further escalation. There's black marketing and all those things. Last time I was up against senior most advocates and people who batted for autonomy. I want to smoke. I want e-cigarette. Who are you to stop me? That was given as a senior most lawyers. And that time I said, okay, we use helmets by law, and I may say that I am driving a two-wheeler, I want to risk my life, I don't want that heated thing in I want to be free. So what if I get injured? So be it. So who is the government to tell me to ban it? It is the responsibility of the state. At one time in Chicago, prostitution was banned. And one of the senior most person during the debate asked, don't Chicagoans know whether to go to prostitute or not to go? It is the responsibility of the state. Today, helmets are banned in Delhi, this is followed. You go to UP, some cities, they are banned, but they are not followed. It doesn't mean that you have to stop banning. You have to follow the science. You have to follow the norms and let the experts decide what is right and what is wrong. Implementation, just because you cannot implement to Toto, you stop implementing. So let the life go like this. And I'm very sure after reviewing the literature and even the scientific studies that have been quoted, majority of these studies are conducted in a controlled environment. Large proportion are funded by the industry. And I have in my mind, I won't take a lot of time. I have no doubt in my mind. I am only focusing on the electronic cigarettes. After studying the subject in threadbare and even knowing about the latest of the studies, I do not think in larger picture that electronic cigarettes are harm reduction to this country at large. To a particular person, maybe. Other thing is that, okay, they are good in England, but can you get a dose of azithromycin antibiotics in England if you wish to get? No, you cannot. You cannot equate Indian setup, socio-economic status and the rules regulation to the England. Study conducted in England showed that, okay, this system of delivering is okay. Long-term effects are not known. The antibiotic abuse is there because they are over the counter, you can get any damn drug. Similarly, if you allow electronic cigarettes in India, anybody can go and get it. I know one school child who was brought by his parent. I asked her, that girl, that where do you get electronic cigarette? बोला अंकल आप बताओ ना कितना चाहिए. I know that, but that's not a solution. Solution is to implement it. And again I am saying, reviewing the whole literature, being part of that expert committee where we threadbare discussed everything, the electronic cigarette is big no-no as far as I am concerned. Thank you.
Thank you, Dr. Killani. So a very quick reaction from you to Dr. Bharat on this, since you've heard everybody speak.
I think I'll get back to that same point. Dr. Killani or me are both doctors, and we are seeing the end result. And as science, we are not going to stand. It's not a pro-con debate. From my side, it was never a pro-con debate. It's something which we all have to sit. A friend from Niti Aayog said, you cannot have, see, we are, as Dr. Ambedkar was saying, it is not possible that you say we are not doing anything for the, have we actually made an attempt to stop the production of smoke, combustible cigarettes? Have we actually looked at the BD industry? I have 3-4 patients who are BD kings, 100% non-taxable. When I have gone to there for a home visit, the money is lying in boris. So let's not close our eyes and think if we are sitting on the other side of the table that we are not. See, we have to understand that these are all separate subgroups. What I told you and what our studies which I have quoted are very, very clear. Therefore, 2 subsets where they have looked at. There are people who are not either willing to leave cigarettes or who have lost, even if Dr. Pavan has tried his best and has not been able to come. Somebody talked about, sir said about someone who has a cardiac, has had an MI, but he still smokes, right? So, should we let him actually keep smoking? My answer is this: he is not ready to take NRTs. As a pulmonologist, I'm very well aware of MRTs and we are giving, but there are people, there will be subset. Now, we have to understand that putting it at a policy level for public health is a different entity altogether. Putting it at a medical level, once you have something like a ban, then it encompasses everything. So, what Australia probably did a year back is something at least allowing those alternative products, at least if it is required. Now, if we look at the point of antibiotics being available, now that's a cultural issue or a societal issue, right? And the fact that we cannot regulate our society doesn't mean we just, then we will have to put banning so many things. We cannot regulate is not the end result for anything to be banned. Forget about, I'm not a proponent of e-cigarette or XYZ. I'm saying if you have an alternative which may be scientifically acceptable in a particular subgroup of my medical patients, should ICMR not actually come out and do a study into it? And let's look at it. It may fail. It will be once and for all, it's over. Let ICMR come out with budget to actually for people who want to actually look at cardiac patients, COPD patients. Let's have a proper inclusive criteria. Sir is very right. All those studies are in controlled environment. Like any other drug is, all studies, all data for any medical profession is all in controlled environment. And what we do is real world work. So that difference will always be there. We are only looking at, so my suggestion in all these meetings is, let's not keep a blind eye and feel that, okay, this is bad. No, who said? My first slide was that don't think that vaping or any of these products are good. If possible, let's have a smoke-free society. It's utopian. It's very difficult, yeah, because it will never occur. So now what we have to aim at is we have to have those pillars of tobacco control. Those 3 pillars are very well established. We have to keep fortifying what Dr. Pavan is doing, what the National Smoking Quit Line is doing. These are things which have to be probably more enforced more properly. But look at the science which is emerging. Look at, for those people who may be requiring these things, why not actually have an option, right? So I'm not talking about moral issues. I'm not talking about the lawyer who said that I want to smoke, I want to kill myself, I will. So that is, you can't actually argue with such people. People, if they want to jump from top of a terrace, you can't say, you have put a sign.
No, I think
Right?
we have to distinguish from there also.
Yeah.
This happened in USA when the helmet enforcement for prevention of head injury amongst the motor two bike riders. So somebody, the case went to this US Supreme Court that it is my freedom and in my life. So US Supreme Court ruled, no gentlemen, it's not you. It may be your life, but whose money is being spent when you get head injury? It's the taxpayer money which is spent on your care. So we cannot leave you at your will to kill yourself or whatever. So if it's a law to put on a helmet and fasten it when you ride a motorbike, you do that. And that has to be there. The only problem with our great country is Bharatvarsh, law enforcement is a huge challenge in every sphere of life. Whether we talk of traffic niyam, whether we talk of drunken driving, whether we talk of anything for that matter. And that is where our challenge lies, that how to enforce. And that's how you saw the protest went on for 1 year. And we just couldn't remove the protesters, and huge population was put to inconvenience. Whether it was anti-CAO protest, whether it's a farmers protest. So rule of law must be prevailed, and it can be prevailed. We saw those examples from Lucknow. We saw those examples from elsewhere that they did not allow, and it did not happen. So if you are soft on enforcing the law, then you get lawlessness. And that is where the challenge lies for all of us, that how to make the rule of law enforced for everything.
Yes, I do agree with you, Dr. Mishra, that India is a country of cultural diversity, economic disparity, and implementation of law enforcement is not the same as in the West, or you talk of UK, USA, Australia. Our problem is different. So we need to look at this issue with a caution. We need to look at, do some rational clinical trials based on our country by the experts. So only then we can reach to a conclusion, because it's a very diverse topic. It's very difficult to decide this way or that way. As Dr. Madan Gopal said, we need to really see what fits best for our country, for that matter. Thank you.
I'll just add it here. What Dr. Sunil said was, I think Dr. Pavan sir is really doing an excellent job about it. Would really appreciate if we can have these ambassadors from the schools, from the colleges, who can be the promoters for your program, because they'll be the best people who can be utilized as a resource. I mean, as a small example, when we had this COVID, even till date, a child who is a 5-year-old refuses to remove the mask. Parents mana karenge jaldi se remove karo, but he would still not remove it because that has been really put it in the, it's there in the gene now, probably, कि नहीं पहनना है निकलना है. So I think because I remember going to a small wedding, and then there was this group of children who were sitting in that alag there were small little areas they had kept from ice cream counters. There was one where they had a hookah. I was standing there and I was waiting for a drink to come, and then I was seeing those small little kids of 8, 9, 10 standard, and they were saying ke aapne auntie kabhi ye liya hai. So I was asking them aap kya le rahe ho. He said आपने कभी पिया नहीं है. I said नहीं लिया है. So he says आपने कभी steam लिया है. मैंने कहा हाँ. तो कहते बस वैसे ही लेना, आप आके try करिए. So I think what you said कि गरम लोहा है, हथौड़ी मारना है, will only
Did you
happen.
try?
So,
I wish I could really do
You
that.
should have tried actually. When the children are trying, you should have tried.
try नहीं करना है.
May I
That is-
request
see,
Dr. Bharat to kindly complete what you were saying? Okay.
So let me okay.
So I think there's nothing
So-
much. We are all discussing the same thing, and finally
So-
we all have to probably reach at a middle path, probably, which is going to be the best from policy
So
making.
let me put it here, Dr. Bharat. The middle path is that we have to make sure that government has banned e-cigarettes. Let's go with it, and let us find out what is the other path with the cigarette ban. Still, we can work out with our patients, right? And let me put it that when you said that the lozenges were not available in your hospital, that implies that you did not take enough of what I'll say, enough of to get it in your hospital. I have got all types of lozenges, gums, everything available in my place. He did not take
Sir,
enough of effort to get it
ऐसा है कि
available.
see, I am.
So let me
listen,
put it
I think
very
it's
clearly.
not a. I told you in the beginning. Let's get not. I showed you a graph, and
Yeah,
I'm used to
let's-
this. He's also used to the other part, and I'm
let's-
also used. Listen, Dr. Pavan, it is not a personal thing. You
No,
are
I'm not talking
into
personally, but I'm just telling this
it's
thing.
not a question of lozenges being available or not available. I can tell you. So let's not get into.
We are
personal
really
things,
running
okay?
short of
Just,
time.
yeah,
and
Let's not
I'll
get
just-
into personal things. I can
Just to
get you
add
the
here,
lozenges on phone.
So Lottie, just one thing.
Yes.
What Sunita has said, just on 24th of August, we had a meeting with CBSE, and that was mainly for the school programs, how to implement this Be Smart, Do Not Start program in the schools.
It will be nice if one person can talk at a time. I think let's allow Dr. Bharat to complete his finishing line.
Okay. Okay, I think then we have somebody who has a question there, right?
नॉट क्वेश्चन
Yeah.
जैसा पवन सर ने बताया है उस तरह से हमारे विश्वविद्यालय में दिल्ली विश्वविद्यालय में वल्लभ भाई पटेल चेस्ट इंस्टीट्यूट है जहाँ की सालों से मिनिमम 15 इयर्स हो गया वहाँ पे टोबैको सेसेशन क्लिनिक चल रहा है, वहाँ मैं काम करता हूँ और एंटीक्विलस बहुत सालों से चल रहा है और ख़ास करके इसलिए वो वहाँ पे खोला गया है क्योंकि दिल्ली विश्वविद्यालय है, वहाँ बहुत सारे बच्चे हैं, आप आमतौर पर आप आते जाते देख सकते हैं, लड़के तो लड़के, लड़कियां बहुत ज़्यादा सिगरेट स्मोकिंग करती हैं। उसके लिए हमारा लीडरशिप ऑफ डॉक्टर राजकुमार अभी डायरेक्टर हैं हमारे, उनके संयोग से पूरे दिल्ली विश्वविद्यालय के हर कॉलेजों में जा कर के हम लोग एक टीम है, वो जाके अवेयरनेस प्रोग्राम करते हैं और टोबैको कैसे रोकना है, यदि कुछ बच्चों को आदत लग गई है कैसे छोड़ेंगे, तो हमारे यहाँ क्लिनिक में वो आते हैं बच्चे। और जो एंटीक्विलस है हमारे यहाँ सर्विसेज है वो 24 आवर्स है और उसमें 40 काउंसलर हैं जो पूरे भारत के बहुत सारे लोग हैं जो टेलीफोनिक माध्यम से वो बात करते हैं कि हम कैसे करें, हमने गांव में शुरू किया है कैसे। और बेसिकली हमारा जो इंस्टीट्यूट है वो अस्थमा और ट्यूबरक्लोसिस के लिए फेमस है, तो वहाँ बहुत सारा जो जैसे सर ने बताया कि 80% जो पेशेंट है बेसिकली डिजीज़ फ्रॉम द टोबैको, चाहे वो सिगरेट के माध्यम से हो, चाहे गांव में जैसे चूल्हा जलाते हैं उसकी वजह से COPD पेशेंट बन गए हैं, तो वो बहुत सारे लोग आते हैं, तो ये एंटीक्विलस बहुत ज़्यादा यूज़फुल है और पूरे भारत के लोग उससे बेनिफिट हो रहे हैं।
Thank you so much. Thank you so much. And now finally I would request Dr. Nimesh Desai to kindly deliver his concluding remarks to this highly informative discussion by all the eminent panelists who took out their precious time from their rather busy schedules. Dr. Desai, your concluding remarks, please. Again, you made a slide, it seems.
I must empathize with Anil and Sajna that the effort and
Sir, you're such a good speaker. Why do you need slides?
Nimesh, again a slide.
No, it's
hold it. Let's all hold it, please. Okay. I must. No, not this one here. Naya file, a consensus. 4 slide ka hai. I may not use it. That's okay. But I must sincerely empathize with Anil and Sajna for the effort that they seem to have made. As they have been saying for last few weeks. पहले last वाले ले आएंगे, please. Thank you, those. Yes. My friend Lottie is a bit surprised why slides. This is why. Not everybody might even agree about this. Okay? But at least this is how I have understood the different viewpoints. I hope at least we agree about this. One, e-cigarettes are harmful, so no review is justified, and so no review. Second, If other HR approaches are okay, why not let e-cigarettes also be one of them? Third viewpoint, bans generally don't work, illicit activities only get enhanced, be realistic. 4, would regulation, even of e-cigarettes, be a better option than a total ban? So, dwell on this, at least we have, what I've tried summarizing is, forget a consensus. At least these are the 4 viewpoints that we seem to have had. Go back please, 2 or 3 slides. Now, what is good is that there's been a lot of concern expressed for health effects of tobacco, the need for control, the need for prevention, the need for treatment. Large part of tobacco this deliberation, I must say, was on prevention of tobacco. And allow me to say, I think large part of that was not really directly relevant to the focus topic. We were talking about treatment for tobacco, cessation, HR approaches. I mean, one can, as citizens, go on long about, why is it happening, youth mein ho raha hai, falan ho raha hai. I mean, that's, sorry, but what is good about that discussion is, Anil, one more time we have this group of people who agree about the concern. Second, if I'm getting this right, please tell me. If I'm not, please tell me. I got the sense that we do not seem to have a problem with the harm reduction approach, and Atul and I, as people who have battled with it in the chemical addiction area for a long time, at least would be satisfied with that consensus. That harm reduction approach is, the principle is all right, the harm reduction approach. If that is so, that's one achievement, Anil, at least that HR as an approach in tobacco cessation, it seems a consensus. Obviously, beyond that, it wasn't agreed to. E-ciggies, like I've said, they are very strong views, especially about safety and then clinical correctness and whatever else. The white paper that Dr. Killani was part of took a position based on how they saw the harm, but I think the colleague also brought out a lot of literature evidence after that. And so to me it would seem, next karenge sir agar hai to? I think Atul made a very good point that some of us have been trying since the morning. See, the thing is, and allow me, now for the first time perhaps since the morning I am coming to my individual viewpoint, if you realize. Since the morning I have tried steering away from my individual, not personal, individual professional viewpoint. For the first time I am coming there at the last minute. I am not at all, like our friend said, for e-ciggies as an accessory push. It's fine if it doesn't happen for the next 10 years. Those of us who are trying to work in the policy or treatment will continue to do so with the approaches that Pavan spoke about. But I do have a serious concern, sir, when you say substitution is not the answer. I really would like to take a very strong view on that, because NRT is substitution. All that we are talking about in e-cigarette is the vehicle and the congener compounds, as they are called. That's all. And about that, my final word, I really agree with our friend who I'm really listening to so well for the first time, must say, Bharat. At least Bharat and Atul and a few other people made this viewpoint. At least let's have those independent researches. Let not any one of us have a prefix value. For the life of me, for last 15 minutes, I'm trying to remember whose quote it is, and if somebody can enlighten, very good. I don't remember, and I don't remember the quote also correctly or who the source was, but something to the effect, and I must say with all respect to all friends, to a great extent, that is what seems to have happened today while there has been a great exchange. And the quote is something to this effect, that discussing or interacting is only to listen to people to adjust them to my views. तो मैं जो व्यू लेके आया था सुबह में वही लेके जाऊंगा, जिसको मैंने सुना उस हिसाब से सुन लिया मैंने जो देखना है, including myself. Please, we are all human and we are all similar in human weaknesses. I would really think that, like Bharat and Atul and a few others have said, I really think my individual view, I think by taking a moralistic extremist view, we are being ostriches. It's very easy to put your head in the sand and say those 10 or 15 or 20 people out of 100 who might need this help, We don't care about them. I have treated 70 others, I have succeeded, you know. But Atul's point was very crucial. Please remember one more time. Empathy for those who by now it is known biologically. And allow me, opioid substitution, Atul perhaps have not even joined. He felt uncomfortable about my calling him young, but at my age he does look young, right? Before I left AMC, we were on his MD thesis together. 80s and 90s went through tremendous problem of opioid substitution. At Indo-US government meetings, in Nirman Bhavan, in Planning Commission, methadone or any substitution, Dak Sahab, forget it. We will never allow it to happen. It's happened. And if many of us in Sharam live long enough, you will see there will have to be more accommodation about scientific evidence not being governed by morality or absolute principles, my hope. Thank you so much for this opportunity. Thank you.
Thank you so much, Dr. Desai. And now may I request Mr. Anil Nair to kindly deliver his vote of thanks, please.
Thank you, Loti. Like Dr. Madan Gopal said, I don't want to stand between a bunch of hungry people and their food. But still, we as policy circle, we wanted from this was a discussion, not a debate. Like Dr. Nimesh Desai said, we should listen to each other and we should go with a more refined viewpoint. That's what I feel these discussions are all about. Today, my job is just to say thanks to all of you who took time to come on a Sunday morning to talk to each other. That's it's really gracious. I really want to thank you for taking your time out and come here. And then I would like to thank Dr. Desai for initiating and wrapping up the discussion so well.
Can I clarify with everyone? I'm very sorry, Lottie. Those 4 viewpoints at least.
Right.
Range of viewpoints. Did I capture that correctly? Because at some stage you want to document, right?
Sure.
So if that is at least agreed, that this was the diverse set of viewpoints.
We appreciate your
That much, sir. ठीक है?
ambition in the viewpoint.
इतना
Yeah.
ही है ना, sir?
Yeah.
Because he'll have to have a document.
Yeah, sure. I think now I will document this. Yeah. I will share it with you once we have a fix on this. We will share it with all the speakers and other participants. My job, as I said earlier, is just to say thanks for all of you who came here today. First of all, I would thank Dr. Desai for initiating and wrapping up the discussion so well. That it makes my life much better, much easier. I would also like to wish to express my thanks to other speakers, Dr. M.C. Mishra, Dr. Madan Gopal, Dr. G.C. Killani, Dr. Jayakumar, Dr. Bharat Gopal, Dr. Preeti Gupta, Dr. Sunil Raheja, Dr. Sunita Mittal, Dr. Pavan Gupta, Dr. Atul Ambekar, and Dr. Sunita Gupta. I also wish to thank all the eminent doctors, journalists, and others who joined us today. And with this, may I request all of you to join us for lunch, which is waiting for you outside, just outside.
One big hand for Lottie, Larry.
Yeah, I was coming there. Yeah, Lottie, you beautifully, conducted the event. I must say that Navin, without your help, nothing would have been possible.
Now we have to wait for her to say, take very good care of yourself.
No, Lottie knows all these doctors, and she spoke to them.
For me, it was like having a Healthy India on a bigger scale, So it's like deja vu for me. So many of them have been my guests and umpteen times. So it's my real pleasure to be here today.
She can control all of us.
Thank you, Lottie. And thank you, all others. Let's rush for lunch. Thank you.
Are you going to prepare a document?
Yes, sir.
The Pavan's suggestion in that replicating the cessation efforts through various courses, capacity building, training the doctors, because doctors are equally ignorant, as I say, and the doctors are ignorant about many things outside their area of comfort zones. If I am a surgeon, I'll see hernia and gallbladder everywhere. Or a cardiologist will see only the MI, or somebody else will see something else. But I think the generalist view has to be there, and what his efforts are, that we have to make people aware that they need to, and I agree with him that we just stop smoking. It doesn't get stopped like that, or don't drink. It doesn't, people don't quit alcohol just like that. So I think that is where every healthcare facility must guide those who come for help. If they don't have in their own setting, they should at least know the place where this person can go and get help. I think that is where that is what Atul's point was. That empathy, what he meant was that at least those who want help, they should get opportunity for the help.
Right.
Yeah.
Definitely, that is one big lesson I also learned from
Also
here.
deserve help. Not
Yeah.
only those who want.
That's right.
Those who are helpless deserve help more.
Yes.
Yeah, thank you.
Yeah.
Yeah.
सर डॉक्टर के लिए बहुत इजी है जो मेरी मदद चाहता है उसकी मैं मदद कर दूंगा ऐसी ट्रेडिशनल मेडिकल
Bring them in the fold. Bring them in the fold.
Right, right.
Actually, that is one big lesson I also learned from here, from Dr. Pavan's work. I think I should go back and start the smoking cessation clinic. Yeah, it should be started. So there is something very great. Yeah.
Yeah.
Very nice.
1 minute, 1 minute. Thank you, doctor.
One clap for Nimesh.
Yeah. Why don't you sit here? Sit.
I to highlight the role of two things that I wanted to touch upon, which I thought have been, just skipped. One was the effect of tobacco on the male reproductive health, which was touched upon. And because the sperm is the only cell which cannot protect itself, because it is totally devoid of any repair mechanisms as well as the antioxidant. And that is actually transmitted to the next generation. So is the cause for childhood cancers, autism spectrum disorders. So I think if you are going to note these points, I think it should be emphasized that the father, when you're taking the history and all, these should also be there. And as we were framing guidelines for Ayushman Bharat wellness guidelines, we highlighted the role of yoga. And I think for harm reduction, it plays a dual role. Firstly, it will help to build emotional resilience in children who are, because they get susceptible to stress, anxiety, they take up smoking and other substance abuse. So in that, and then the other thing is when they are actually smoking, then it's been seen that yoga actually switches on gene programs which are beneficial for health, the DNA repair mechanisms. So I think the role of yoga cannot be ignored, and it should be highlighted that if you want to reduce the damage done by nicotine, you have to, if they can adopt yoga, and that's what we emphasize, that it should be told to the parents, and if this can be introduced in schools, it's so important that beyond just the cardiovascular and the effect on the lungs and other systems, how it causes accelerated aging, how it is affecting the germ cells, and I think if the boys become aware, they may not even take up smoking. And also if we sensitize the ASHA workers about the role of yoga and how smoking is impacting at your young age, that would have to percolate down the society to parents and children. Thank you.
Thank you so much, Dr. Rima. Those were really pertinent points. So thank you so much, everybody, for coming here on a Sunday morning, as everybody has been saying. And it was a very interesting conference, and I hope all of us will take back a lot home today, especially young students sitting here. So now, before any further ado, let's just go and have our lunch. Do join us.